Wake up to reality. Nothing ever goes as planned in this accursed world. The longer you live, the more you will realize that the only things that truly exist in this reality are merely pain, suffering, and futility. Everywhere you look in this world, wherever there is light, there will always be shadows to be found as well. The selfish intent of wanting to preserve peace initiates wars, and hatred is born in order to protect love. There are nexuses, causal relationships that cannot be separated. Listen.
парень и меняет тайный парень. Гонг сам спекляс, боков и дай сильный парень. Залетаю, как цунами на биты и становлюсь как я. Рэп-игрей.
Следующий уровень пробоя у нас 80, ребят. Вот этот. Сейчас мы на 67. То есть сейчас пробьем 68,5. В текущий момент мы здесь. И от текущих мы летим вот сюда минимум. В текущий момент. И уже у нас в профите порядка, хрен его знает, я от 52 еще писал, он давал до 76, ну что-то в районе 50%, вообще любому, даже мозги не нужно, просто вот купить, тупо продать, тупо. Я могу так и оставить этот экран. Просто будете смотреть на чат. Не знаю, здесь ли тут Серега онлайн. Я не знаю, можно ли как-то поднять качество видео стрима с 720 до 1080. Потому что у меня что-то ни хрена не получается. У меня, правда, был прокси включен, но сейчас я его выключил. Но что-то качество не поднимается. Пробили еще один уровень. 67. 0,786. Это вот эти вот значения. Значит, следующее 80. 79, вернее. От текущих до 79. До 79 точно сейчас дойдет. Еще можно отправить донат через канал, там ссылка есть активная. Если хотите видеть, что именно, где я продаю, покупаю. Пока будем в таком режиме работать. Так, началась трансляция.
Okay, sorry about that. My fault. For topics such as those being discussed at this meeting, there are often a variety of opinions, some of which are quite strongly held. Our goal is to be fair and open, and that individuals can express their views without interruption. Thus, as a gentle reminder, individuals will be allowed to speak into the record, recognized by the chairperson. We look forward to a productive meeting. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the Advisory Committee take care that their conversations topics take place in the open forum of the meeting. We are aware that members of the media are anxious to speak with the FDA about these proceedings. However, FDA will refrain from discussing the details of this meeting with the media until its conclusion. Also, reminded to please refrain from discussing the meeting topic during breaks or lunches. Thank you. Dr. Moon-Hee Choi will read the conflict of interest statement for the meeting.
The Food and Drug Administration is convening today's meeting of the Cardiovascular and Renal Drug Advisory Committee under the authority of the Federal Advisory Committee Act of 1972. With the exception of the industry representative, all members and temporary voting members of the committee are special government employees or regular federal employees from other agencies and are subject to federal conflict of interest laws and regulations. The following information on the status of this committee's compliance with federal ethics and conflicts of interest laws, covered by but not limited to those found at 18 U.S.C. Section 208, is being provided to participants in today's meeting and to the public. FDA has determined that members and temporary voting members of this committee are in compliance with federal ethics and conflict of interest laws. Under 18 U.S.C. Section 208, Congress has authorized FDA to grant waivers to special government employees and regular federal employees who have potential financial conflicts when it is determined that the agency's need for a special government employee's services outweighs his or her potential financial conflict of interest, or when the interest of a regular federal employee is not so substantial as to be deemed likely to affect the integrity of the services which the government may expect from the employee. Related to the discussions of today's meeting, members and temporary voting members of this committee have been screened for potential financial conflicts of interest of their own, as well as those imputed to them, including those of their spouses or minor children, and for purposes of 18 U.S.C. Section 208, their employers. These interests may include investments, consulting, expert witness testimony, contracts, grants, creatives, teaching, speaking, writing, patents and royalties, and primary employment. Today's agenda involves the discussion of new drug application NDA 215-8484 for the NRF2 activator for doxolone methyl capsules submitted by Reata Pharmaceuticals Incorporated. The proposed indication is to slow the progression of chronic kidney disease caused by Alport syndrome in patients 12 years of age and older. This is a particular matters meeting during which specific matters related to Reata Pharmaceuticals NDA will be discussed. Based on the agenda for today's meeting and all financial interests reported by the committee members and temporary voting members, no conflict of interest waivers have been issued in connection with this meeting. To ensure transparency, we encourage all standing committee members and temporary voting members to disclose any public statements that they have made concerning the product at issue. With respect to FDA's invited industry representative, we would like to disclose that Dr. Jerome Rossert is participating in this meeting as a non-voting industry representative, acting on behalf of regulated industry. Dr. Rossert's role at this meeting is to represent industry in general and not any particular company. Dr. Rossert is employed by AstraZeneca. We would like to remind members and temporary voting members that if the discussions involve any other products or firms not already on the agenda for which an FDA participant has a personal or imputed financial interest, the participants need to exclude themselves from such involvement, and their exclusion will be noted for the record. FDA encourages all other participants to advise the committee of any financial relationships that they may have with the firm at issue. Thank you.
We will proceed with FDA introductory remarks from Dr. Elisa Thompson.
Thank you. Again, this is Elisa Thompson. Good morning, everyone, and thanks in advance to our committee members for their participation in today's meeting. The purpose of today's meeting is to discuss the marketing application for bardoxolone methyl to slow the progression of kidney disease in patients 12 years of age and older with chronic kidney disease caused by Alport syndrome. As you'll hear, Alport syndrome is a serious and rare genetic disease that can lead to progressive loss of kidney function and kidney failure, sensory neural deafness, and ocular abnormalities, which can lead to loss of vision in some patients. As you'll also hear, there are no approved pharmacologic therapies for Alport syndrome, and there is urgent need for safe and effective treatment. I apologize. I'm hearing some backup or some additional noises. Thank you. In support of the proposed indication, the applicant conducted a randomized, double-blind, placebo-controlled study in patients with Alport syndrome. The study met its pre-specified primary and key secondary endpoints, which assessed on-treatment and off-treatment changes in kidney function as measured by estimated glomerular filtration rate, or eGFR. Nevertheless, we are bringing this application to an advisory committee because we believe the findings in the trial warrant public discussion. I want to emphasize that the FDA review team recognizes that there is significant unmet need for treatments that can slow the loss of kidney function in patients with Alport syndrome and reduce the risk of progression to kidney failure. I also want to emphasize that the FDA review team recognizes that the law allows for regulatory flexibility in determining what constitutes substantial evidence of effectiveness to the extent that such approaches are scientifically valid and do not compromise our regulatory standards of effectiveness. However, for the reasons that will be discussed today, the FDA review team does not believe the submitted data demonstrate that bardoxolone is effective in slowing the loss of kidney function in patients with Alport syndrome and reducing the risk of progression to kidney failure. As a backdrop to today's discussion, I would like to briefly discuss changes in eGFR as the surrogate endpoint in trials of chronic kidney diseases. Kidney failure is associated with significant morbidity and mortality. However, it is also a late outcome of chronic kidney diseases. As such, we often use a surrogate endpoint, specifically changes in eGFR, to assess whether a drug is effective in reducing the risk of progression to kidney failure and as a basis for full approval of drugs intended to treat chronic kidney diseases. I know that our advisory committee members are very familiar with the term surrogate endpoint, but for those of you in the audience who are not, surrogate endpoint is a clinical trial endpoint used as a substitute for a direct measure of how a patient feels, functions, or survives. The surrogate endpoint does not measure the clinical benefit of primary interest. Rather, it is expected to predict that clinical benefit. Over the last decade, our understanding of changes in eGFR as a surrogate endpoint for progression to kidney failure in trials of chronic kidney diseases has grown dramatically as the result of important work that was done by the larger nephrology community. And while there is an abundance of evidence supporting the use of eGFR as a surrogate endpoint, there is a catch. Drugs can have reversible pharmacodynamic effects on eGFR, and by that, I mean drugs can cause reversible increases in eGFR or reversible decreases in eGFR. Importantly, these reversible pharmacodynamic effects can differ from a drug's long-term effects on progression to kidney failure. These reversible pharmacodynamic effects are often of unclear clinical significance. Moreover, they can complicate the ascertainment of a drug's effect on long-term disease progression. In the case being discussed today, the reversible effect is an increase in eGFR, which appears to take several months to manifest fully. In the case being discussed today, we also see worrisome effects on albuminuria and blood pressure. So with that background in mind, I'd like to turn to the topics we would like the committee to address. The first topic we would like the committee to consider is whether Cardinal Phase 3 was adequately designed to assess for an effect on the progression of chronic kidney disease in patients with Alport syndrome. The second topic is whether the available data indicate that bardoxolone methyl slows the progression of chronic kidney disease and whether it is reasonable to conclude, based on the available data, that bardoxolone methyl will reduce the risk of progression to kidney failure when used chronically in patients with Alport syndrome. The third topic is bardoxolone methyl's safety profile. And as part of the discussion of this topic, we asked that the committee include discussion of two questions. The first pertains to bardoxolone methyl's effect on albuminuria, blood pressure, and other parameters, and whether these effects raise concern about its long-term efficacy and/or safety in patients with Alport syndrome. The second pertains to the effect of bardoxolone methyl on body weight and the potential implications for pediatric patients. Finally, we asked the committee to vote on whether the evidence demonstrates that bardoxolone methyl is effective in slowing the progression of chronic kidney disease in Alport syndrome and whether its benefits outweigh its risks. Although we are interested in how you vote, I want to emphasize that we are particularly interested in the rationale behind your recommendation. And with that, I will turn the program back to Dr. Lewis, our committee chair. Thank you again for your time and for your help with this very important application.
Thank you, Dr. Thompson. Both the Food and Drug Administration and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the advisory committee meeting, FDA believes it is important to understand the context of an individual's presentation. For this reason, FDA encourages all participants, including the applicant's non-employee presenters, to advise the committee of any financial relationships that they may have with the applicant, such as consulting fees, travel expenses, honoraria, and interests in the applicant, including equity interests and those based upon the outcome of the meeting. Likewise, FDA encourages you at the beginning of your presentation to advise the committee if you do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your presentation, it will not preclude you from speaking. We will now proceed with the Reata presentation.
Good morning. I'm Dr. Melanie Chin, and on behalf of Reata Pharmaceuticals, I thank the advisory committee members and the FDA for the opportunity to present our data supporting the efficacy and safety of bardoxolone methyl for the treatment of Alport syndrome. Most importantly, we thank the patients suffering from this rare and serious disease who have participated in our clinical trials, especially during the pandemic. Bardoxolone methyl received orphan drug designation from the FDA, and the proposed indication states, bardoxolone methyl is an NRF2 activator indicated for the treatment of chronic kidney disease caused by Alport syndrome in patients 12 years of age and older. Bardoxolone methyl has been shown to slow the progression of kidney disease in Alport syndrome. It is an oral, immediate-release capsule that comes in two strengths, 5 and 15 milligrams, and is intended for chronic daily administration. A dose titration schedule, which is based on a patient's pre-treatment urinary albumin to creatinine ratio, or UACR, is used to determine the target goal dose of 20 or 30 milligrams. Alport syndrome is a rare, serious, and rapidly progressive hereditary form of chronic kidney disease, often diagnosed in childhood. There are no approved therapies. Mutations in the type 4 collagen gene lead to structural defects in the glomerular basement membrane that cause inflammation, fibrosis, and loss of kidney function. Ultimately, patients progress to kidney failure. Bardoxolone methyl, which we will refer to as bardoxolone, targets chronic inflammation, which is known to drive CKD progression. Chronic inflammation impairs single nephron GFR through its dynamic regulation and reduction of glomerular filtration surface area. In addition, it also induces profibrotic pathways that provoke irreversible kidney remodeling, resulting in nephron loss. This plot shows the link between inflammation and CKD progression in Alport syndrome. The number of inflammatory cells is shown on the x-axis and serum creatinine levels on the y-axis. These kidney biopsy data demonstrate that the degree of inflammation is significantly correlated with declining kidney function in Alport syndrome. Bardoxolone's novel mechanism of action activates NRF2, a transcription factor with anti-inflammatory and tissue protective effects. By activating NRF2, bardoxolone reduces oxidative stress to restore redox balance, reduces mitochondrial dysfunction, and suppresses inflammation and fibrosis. NRF2 has been shown to be suppressed in many forms of CKD and is linked to EGFR loss, and it has been validated as a therapeutic target in genome-wide studies of patients with 9 different forms of CKD, including Alport syndrome. Most existing therapies address CKD by reducing hydrostatic pressure within the kidney and do not directly target inflammation. We and our collaborators have characterized bardoxolone's novel mechanism in 20 different models of kidney disease. Using in vivo imaging, we have shown that through activation of NRF2, bardoxolone acutely restores the filtration surface area in the glomerulus, and as a result, increases single nephron GFR. Importantly, this is not associated with increases in glomerular permeability or pressure, which would be harmful. Chronic treatment with bardoxolone slows disease progression through its antifibrotic effects, which take longer to manifest. The caller has disconnected the line. Goodbye.
Panel member assistance team with FDA staff, please hold on the line. You are not disconnected. Please hold.
Test.
Test one.
I can hear you. Can you hear me? The slides aren't moving and I can't hear the speaker.
Okay. We'll start again. Chronic treatment with bardoxolone slows disease progression through its antifibrotic effects, which take longer to manifest. We see suppression of inflammatory cytokines, as well as reductions in growth factors and extracellular matrix deposition, all of which prevent structural damage. We've demonstrated these effects in models of CKD, including hyperfiltration, protein overload, and diabetes. These multiple lines of evidence show that bardoxolone targets the underlying pathophysiology of CKD and provided scientific support for its clinical development. We began studying bardoxolone back in 2005 in oncology, and during these early studies, we noted effects on EGFR in patients with cancer, which led Reata to investigate bardoxolone in patients with CKD. Between 2008 and 2012, we conducted multiple trials in patients with type 2 diabetes and CKD. In 2012, Reata stopped clinical development with bardoxolone in diabetic CKD after a safety finding in a large phase 3 trial. While our Japanese partners continued development in diabetic kidney disease, Reata decided to focus on developing therapies for rare diseases, and we began our development program in Alport syndrome in 2016. As you will hear today, these early CKD trials informed our development program. Across all studies, we have noted the following observations. First, increases in measured GFR with bardoxolone, confirming that the change in estimated GFR represents a true change in kidney function. Reductions in markers of vascular inflammation and injury. Preservation of eGFR observed in studies that included 6 different forms of CKD. Sustained preservation of eGFR in longer-term studies. And finally, off-treatment eGFR benefits after treatment withdrawal of drug. Our entire CKD development program has enrolled over 3,000 patients and exposed over 2,500 subjects to bardoxolone, extensively characterizing its profile. As mentioned, our development has included challenges as well as important learnings. Study 903, otherwise known as Beacon, was the largest of these earlier studies and enrolled patients with type 2 diabetes and stage 4 CKD. Study 903 was terminated due to an increase in adjudicated heart failure events. After halting clinical development in diabetic CKD, we worked to understand this important safety finding. The increased risk for these events was limited to the first 4 weeks after treatment initiation. A series of post-hoc analyses indicated to us that bardoxolone was causing volume overload, which may have led to the heart failure seen in study 903. We also saw imbalances in general fluid and edema-related adverse events. Patients reported sudden increases in weight and blood pressure, but generally had preserved ejection fraction. There was no signal for myocardial injury, and troponins were unchanged. Importantly, we were able to identify risk factors for these events: BNP greater than 200 picograms per mil, and a prior history of heart failure. For patients without these risk factors, the risk for heart failure was 2% for bardoxolone and placebo. Our learnings from study 903 allowed us to continue clinical development with bardoxolone. In all studies conducted since 2012, shown here in yellow, we excluded patients with the risk factors identified in study 903. These trials have exposed over 600 patients, and as we will discuss in the safety presentation, we have not observed the risk for heart failure in patients with Alport syndrome, other forms of chronic kidney disease, or pulmonary hypertension. There were several factors that prompted us to initiate clinical development in Alport syndrome. From a scientific perspective, NRF2 suppression and increased inflammation is linked to eGFR loss and disease progression in Alport syndrome. Additionally, we were focused on developing therapies for rare diseases with significant unmet need, and the unmet need in Alport syndrome is clear. These patients have one of the most rapid rates of progression and reach end-stage kidney disease at a relatively young age, and yet there are no approved therapies. The sustained preservation of eGFR with bardoxolone seen in prior CKD trials could therefore be a meaningful benefit for this population. Importantly, these patients generally have few comorbidities that predispose them to the risk of heart failure previously seen in study 903. Here, we show key baseline characteristics of the study 903 population on the left and the randomized population from our pivotal Alport syndrome study, otherwise known as Cardinal, on the right. The studied Alport syndrome population was much younger than the 903 population, and few had a history of diabetes. And by design, few patients with Alport syndrome had any history of cardiovascular disease, and patients had meaningfully lower baseline BNP levels than the patients in 903. This is consistent with the estimates for the overall Alport syndrome population, where less than 1% of patients had cardiac disease. And since study 903 only enrolled stage 4 CKD patients, baseline eGFR was meaningfully lower. And now, turning to our key development program milestones. In 2016, we had our pre-IND meeting where we agreed upon an adaptive phase 2-3 study design with the FDA. Because of bardoxolone's acute pharmacodynamic effects on kidney function, the FDA was clear that an off-treatment eGFR assessment was required to evaluate the drug's effect on the slowing of disease progression. We incorporated the FDA's recommendations, including assessments of off-treatment endpoints at weeks 52 and 104. In the study may proceed letter received in December 2016, FDA reiterated that the key secondary off-treatment endpoint following a 4-week withdrawal period was essential for approval. After that, as shown below the timeline, we initiated the open-label phase 2 trial in 2017, and FDA granted orphan drug designation later that year. Once the phase 2 trial met its primary endpoint, we initiated the phase 3 trial. And study 1803 began in 2019 and is currently ongoing. We had a series of FDA interactions and submissions after year 1 of study 1603 phase 3 was completed, which culminated in a pre-NDA meeting in September 2020, and we submitted the NDA in February 2021. Which brings us to this meeting today, where you are being asked to consider the benefit-risk of bardoxolone for the treatment of Alport syndrome. Today, you will hear that Alport syndrome is a rare, serious, and rapidly progressive kidney disease with an urgent need for effective treatment. We will begin by talking about the trial design for study 1603 phase 3, including data supporting the adequacy of the off-treatment duration to assess bardoxolone's effect on kidney disease progression. We will then share the bardoxolone efficacy results. Study 1603 phase 3 met its year 1 and year 2 primary and key secondary endpoints, and we will show these results are clinically meaningful and consistent and show bardoxolone slows the progression of kidney disease. We will discuss the safety results demonstrating a well-defined, clinically manageable safety and tolerability profile. And finally, the totality of evidence support a favorable benefit-risk for bardoxolone in the treatment of Alport syndrome. In a moment, Dr. Brad Wardy will provide a background on Alport syndrome and the need for therapies. Next, Dr. Colin Meyer and Dr. Nathan Tusher will discuss our phase 3 study design. Dr. Meyer will then present our clinical efficacy and safety data. And finally, Dr. Glenn Chertow will provide an overview of the benefit-risk of bardoxolone in patients with Alport syndrome. Additionally, our Reata functional area experts and the following external subject matter experts are with us to help answer your questions today. I will now ask Dr. Brad Wardy to speak about Alport syndrome and the need for effective treatments.
Thank you, Dr. Chin. I'm Brad Wardy. I'm the Director of the Division of Nephrology and the Director of Dialysis and Transplantation at Children's Mercy Kansas City and Professor of Pediatrics at the University of Missouri Kansas City School of Medicine. I've cared for children and adolescents with Alport syndrome throughout my career in nephrology, which spans nearly 40 years. I'm also a member of the Medical Advisory Committee of the Alport Syndrome Foundation. I've served as an advisor to Reata over the course of study 1603 phase 3, and in turn, I am a paid consultant to Reata Pharmaceuticals. However, I have no financial interest in the outcome of this meeting. Alport syndrome is a rare, serious, and debilitating disease. It's an inherited form of chronic kidney disease and is caused by mutations in type 4 collagen genes COL4A3, COL4A4, and COL4A5. It affects an estimated 30,000 to 60,000 patients in the U.S., with an estimated 14,000 patients diagnosed in the U.S., and it causes progressive chronic kidney disease. In addition to the kidney disorder, patients with Alport syndrome experience deafness, eye abnormalities, and the emotional burdens associated with chronic kidney failure. Alport syndrome accounts for 3% of pediatric and 0.2% of adult patients who develop end-stage kidney disease annually. Thus, this clearly is a very rare disorder, but patients with Alport syndrome have a high lifetime risk for progression to kidney failure. Why does kidney failure occur in patients with Alport syndrome? As mentioned earlier, we're starting with a genetic insult, and at least currently, we can't change the genetics. But on top of that genetic insult, we have inflammation, and that inflammation leads to glomerulosclerosis, interstitial fibrosis, and ultimately fibrosis of most, if not all, of the previously functioning kidney, with the subsequent development of end-stage kidney disease in many of these patients. The current standard of care for patients with Alport syndrome includes the use of ACE or ARB therapy. While this therapy does have some impact on slowing the progression of CKD, most of these patients continue to progress despite this therapy. And some patients do not even tolerate the therapy, becoming hypotensive, a complication leading to discontinuation of that treatment. Most important is the recognition that RAS inhibition modulates GFR by addressing hydrostatic pressure, but it does not directly impact inflammation, which is the key driver of kidney function decline. Other approaches to the management of CKD and end-stage kidney disease include diet modifications and restricted fluid intake, interventions that are understandably challenging for many and especially for adolescents. Finally, as a result of the many clinical complications experienced by these patients that require care from a variety of disciplines, including physicians, nurses, social workers, dietitians, audiologists, psychologists, all to address the clinical and psychosocial burdens that accompany Alport syndrome. Here are the 4 different inheritance patterns of Alport syndrome and the associated risk of end-stage kidney disease. I want to bring your attention to the bottom row where, as you can see, the risk of end-stage kidney disease and the need for either dialysis or a kidney transplant in those with the most severe Alport syndrome, namely males with X-linked disease and males and females with autosomal recessive disease, is 100%. All of these individuals will progress to kidney failure. And for females with X-linked disease, up to 25% of those patients will also develop kidney failure. In addition to the substantial risk for end-stage kidney disease, patients with Alport syndrome experience a more rapid decline in kidney function than patients with many other forms of kidney disease. Here we see the average annual fall in GFR, or disease progression rate in mils per minute, of patients with a variety of kidney disorders. First 4 groups of patients have a fall in GFR of around 2 mils per minute per year. This includes diabetic CKD patients, hypertensive CKD, patients with polycystic kidney disease, and children with CACT, congenital anomalies of the kidney and urinary tract, the most common disorder associated with kidney failure in children. 2 mils per minute is much slower than what we see in patients with Alport syndrome. For all patients with Alport syndrome, children and adults, you can see the fall in GFR is nearly 5 mils per minute per year, more than double the rate of the other forms of CKD. And as you can see on the far right, the Alport syndrome pediatric population enrolled in study 1603 phase 3 experienced a remarkably high pretrial rate of eGFR decline of 10.7 mils per minute per year. Shown here is the 5-year historical pretrial fall in GFR for the overall study 1603 phase 3 cohort in gold, and the same data for the adolescent patients alone in purple. 0 years represents the initiation of study 1603 phase 3, and end-stage kidney disease is represented by the dotted horizontal gray line. If these same patients followed the same trajectory of kidney function decline over subsequent years following the initiation of study 1603 phase 3, on average, the pediatric patients would progress to end-stage kidney disease in less than 5 years, and all patients would develop kidney failure in only 9 years. At the same time, it's important to recognize, as demonstrated here, that an intervention that can slow the rate of kidney function decline, even by as little as 1 to 2 mils per minute per year, has the potential to delay the development of end-stage kidney disease. For this reason, we assess eGFR regularly to monitor kidney function and track disease progression in patients with chronic kidney disease. While traditional endpoints in trials that enroll larger CKD populations included clinical outcomes such as end-stage kidney disease or a 40 to 50% decline in eGFR, the National Kidney Foundation, FDA, and EMA recognized the need for alternate eGFR-based endpoints, particularly for clinical trials in rare diseases or earlier stages of CKD. As a result of the NKF FDA EMA working group performed a meta-analysis of observational studies in clinical trials and validated that beneficial treatment effects on eGFR as little as 0.75 mils per minute per year assessed over 2 years were associated with reductions in the risk for kidney failure. And FDA now accepts eGFR change as a validated surrogate for clinical trials in CKD to measure disease progression. This is extremely significant to patients because of the increasing array of adverse clinical manifestations that develop with progression from mild to moderate CKD to end-stage kidney disease. A decline in eGFR impacts the clinical manifestations patients experience with CKD. Patients who entered study 1603 phase 3 had eGFR values of 30 to 90 mils per minute, corresponding to stage 2 or stage 3 CKD, where they demonstrated some proteinuria, fluid retention, and maybe hypertension. As eGFR declines towards stage 5 CKD, which is synonymous with end-stage kidney disease, there are additional clinical manifestations: anorexia, acidosis, anemia, and growth delay in children. The patients are fatigued and suffer from a poor quality of life, as many end up requiring chronic dialysis. And as some of you well know, the medical and psychosocial burden associated with dialysis for any patient, let alone an adolescent, cannot be overemphasized. From the medical perspective, I must add that the prevalence of cardiovascular disease is markedly increased in both adults and children on dialysis. In addition, employment, school attendance and performance, family dynamics, future goals, and more are all affected by the need for dialysis, and depression is an all too common result. When children and adults develop end-stage kidney disease, there's also an associated decreased life expectancy for those patients on dialysis. The data on this slide, generated from the database of the United States Renal Data System, represents the estimated years of life expectancy lost for patients by the age of end-stage kidney disease onset. I highlight here the ages of 15 through 29 years, since that is the age range when the vast majority of individuals with the most severe forms of Alport syndrome develop end-stage kidney disease. And you can see that in this population of patients, their loss of life expectancy is an average of almost 40 years. Their lifetimes are basically cut in half. Understandably then, in addition to the medical impact of Alport syndrome, there are often significant psychosocial implications associated with this disorder. At the 2018 FDA patient-focused drug development meeting, individuals with Alport syndrome voiced their concerns. They emphasized that anxiety, depression, fatigue, and hearing loss most negatively impacted their daily living. Almost 3/4 of the patients said that the disease interfered with their daily life, and 1/4 of them reported having anxiety or depression related to the fear of developing kidney failure. And on a personal note, the vast majority of my patients with Alport syndrome and moderate to severe CKD are seeing a psychologist for just this reason. Not surprisingly, these patients also related how they are most interested in a medication that would slow their decline in kidney function. Because in their mind, it's not if, but it's when will they develop kidney failure. In short, new therapies are needed for Alport syndrome. There is no approved effective treatment. As I've shown you, this is a rare, serious, and debilitating disease which often presents in childhood. And the rapid decline in kidney function has a significant impact on patients' quality of life, and in fact leads to reduced life expectancy. And I think it goes without saying that if these patients could have available to them a therapy that has even a small treatment effect and that slows progression by as little as 1 to 2 mils per minute per year, it could result in a meaningful delay to kidney failure. Having this option would, without question, provide profound medical and psychosocial benefits to patients with Alport syndrome. Thank you for your attention. And now I'd like to turn the presentation over to Dr. Meyer.
Thank you, Dr. Wardy. Good morning. I'm Dr. Colin Meyer, Chief Research and Development Officer at Reata Pharmaceuticals. I'll now discuss key elements of the study design of our Phase 3 Alport syndrome trial. As Dr. Chen discussed in our pre-IND interactions, the FDA proposed a Phase 2-3 study design with a 2-year treatment duration and inclusion of off-treatment EGFR endpoints. We incorporated all of the FDA suggestions into the study design and conducted the 3 trials shown here that are central to our NDA. Study 1603 Phase 2, an open-label trial that enrolled 30 patients and had the same treatment and visit schedule as the Phase 3 trial. While this was a 2-year trial, the first 12 weeks established preliminary efficacy and safety in this patient population and gated enrollment in the Phase 3 trial. The pivotal study 1603 Phase 3, a randomized, double-blind, placebo-controlled 2-year trial that enrolled 157 patients, which provides the primary evidence for the NDA. And study 1803, an ongoing, open-label, extended access trial that allows for evaluation of longer-term safety. The endpoints and design of study 1603 Phase 3 are consistent with recent findings from the NKF, FDA, and EMA. As discussed by Dr. Wardy, even small treatment effects on EGFR, a validated measure of disease progression, can translate to a beneficial effect on clinical outcomes in CKD. The primary endpoints for our trial assessed on-treatment changes in EGFR over a 2-year duration. For agents that have an acute pharmacodynamic effect, the working group recommended obtaining a before-treatment EGFR value and EGFR values after withdrawing treatment to assess for any persisting effect on kidney function that would represent slowing of disease progression. Study 1603 evaluated this off-treatment endpoint twice, after 1 and 2 years of treatment. To assess both the on and off-treatment EGFR effects with bardoxolone, study 1603 Phase 3 included 2 48-week treatment periods and 2 4-week withdrawal periods, shown in yellow between weeks 48 and 52 and weeks 100 and 104. A total of 15 EGFR values were collected throughout the study period, as noted by the solid black dots near the top of this slide. For patients who discontinued treatment, we obtained an off-treatment EGFR value 4 weeks after their last dose. Patients were randomized 1-to-1 to receive bardoxolone or placebo starting at 5 milligrams once daily and titrated in the first 6 to 8 weeks to reach their target goal dose of 20 or 30 milligrams. We included off-treatment periods after both years of treatment because during our pre-IND meeting, the FDA indicated that the year 1 data might support accelerated approval. As noted earlier, FDA stated that the 4-week off-treatment EGFR endpoint at week 104 would be critical for demonstrating efficacy and supporting full approval. To characterize the on-treatment effects that would inform use in clinical practice, we included on-treatment EGFR assessments at weeks 48 and 100. To address FDA's guidance, we incorporated the off-treatment EGFR assessments at week 52 and 104, 4 weeks after drug withdrawal. Other exploratory endpoints included a patient-reported outcome, the Patient Global Impression of Change, or PGIC, and frequency and time to first event in a composite of adverse kidney outcomes. Study 1603 Phase 3 enrolled patients with a genetic or histological confirmation of Alport syndrome who were 12 to 70 years of age. Based on feedback from the FDA, we allow patients with a wide range of kidney function, including EGFR values between 30 and 90 ml per minute, which represents CKD stages 2 and 3. Patients with UACR up to 3,500 milligrams per gram were eligible to participate in the trial and were required to be receiving standard management with RAS inhibitors unless contraindicated. Based on learnings from study 903, we excluded patients with clinically significant cardiovascular disease or BNP greater than 200 picograms per mil at baseline. Our earlier trials informed dose selection in our Alport syndrome program. Study 902 was an open-label dose-ranging study in patients with type 2 diabetes and CKD that studied fixed doses of bardoxolone up to 30 milligrams. Increases in eGFR were dose-dependent and maximal at 15 to 30 milligrams with an appropriate safety profile. The efficacious dose was dependent upon baseline UACR. Study 903 used a fixed 20 milligram dose. One key learning from the trial was that dose titration could optimize patient tolerability and allow for careful monitoring. These learnings informed the dosing schemes used in all studies conducted after Study 903. I will briefly summarize our key regulatory discussions regarding the off-treatment duration. After our 2016 interaction, where FDA stated the importance of the week 104 off-treatment endpoint, the first discussion of the adequacy of the off-treatment duration occurred in January 2020 in connection with FDA's review of the year one data. We did, however, discuss this topic in 2018 at an end-of-phase 2 meeting for our AD-PKD phase 3 study, which uses the same treatment duration and off-treatment eGFR endpoints. We provided PK and clinical data, much of which is included in section 9.3 of our briefing book, and the FDA stated that it was reassured by the data supporting the 4-week withdrawal period. Dr. Nathan Tusher will now present these and other data that we use to justify the duration of the off-treatment period.
Thank you, Dr. Meyer. Good morning. I'm Dr. Nathan Tusher, Vice President of Integrated Drug Development at Certara. I am a paid consultant to Reata Pharmaceuticals, and I have no financial interest in the outcome of this meeting. I will discuss the data and methods used by Reata to justify the off-treatment duration used in Study 1603. These are hypothetical eGFR profiles for 3 different drug effect scenarios following treatment for 100 weeks, followed by a washout period. The placebo group in gray declines over time due to natural disease progression. A drug with only acute PD effects is shown as the green dotted line, and a drug with both acute and disease-modifying effects as the purple dashed line. The ability to accurately discriminate the contribution of these 2 effects is dependent upon the duration of the clinical study. Analysis that includes only the data after chronic administration is not capable of differentiating the green and purple lines. The most robust scientific approach to address this question is to also analyze data that only includes one of the effects. The same hypothetical eGFR profiles from the prior slide depict drug treatment for 8 weeks. The green and purple lines representing the acute PD effects only and acute and disease-modifying effects respectively overlap and are identical. Therefore, this short duration study represents a clinical model of the acute PD effects because there has not been time to accrue longer disease-modifying effects. The acute PD effects are most easily identified using short-term clinical studies. Reata conducted 2 short-term clinical studies to define the duration of acute eGFR effects, and we believe that the data support the 28-day washout period. In contrast, the FDA used a PK/PD model based on long-term data to evaluate the acute eGFR effects. Bardoxolone has a pharmacokinetic half-life of 48 hours in short and long-term studies, and there are no active metabolites. As shown in this plot, 14 days after the last dose, approximately 99% of the drug is cleared, and bardoxolone plasma levels would be well below the window of pharmacologic activity based on non-clinical pharmacology studies. Therefore, a short-term study with a minimum washout of at least 14 days should give insight into the pharmacodynamic effect washout period. This table shows the summary eGFR measurements for the 98 patients enrolled in studies 801 and 1102, both short-term studies of 4 and 8 weeks in treatment duration. These short-term studies are not confounded by disease progression or disease-modifying effects. The on-treatment change from baseline values show acute increases in EGFR, and the 4-week off-treatment change from baseline values in the last column show complete resolution of this effect. These results provide strong evidence that the acute EGFR effects resolve within 28 days or 4 weeks after treatment discontinuation. This plot shows over 1,000 individual EGFR values post-withdrawal from 652 patients with various forms of CKD from the Integrated Summary of Safety database. Off-treatment EGFR values are shown from 1 to 42 days after withdrawal. As you can see, over the first 14 days post-withdrawal, the EGFR change resolves, and the best fit line shows no association between EGFR change and days post-dose after 14 days. Importantly, between days 28 and 42, the EGFR change from baseline is constant, suggesting that after week 4, there is no further change in EGFR. The FDA used a PK/PD model to extrapolate beyond the observed 28-day data for estimation of the time to EGFR effect resolution. The FDA PK/PD model was based on data from the long-term study 1603 and the intermediate-term study 005. Both of these studies have sufficient treatment duration to accrue disease-modifying effects. Importantly, the FDA model did not include EGFR data from short-term studies 801 and 1102. Thus, the single EGFR effect estimated in the FDA model likely includes both acute EGFR effects and disease-modifying effects, which can confound the interpretation of the FDA model results and extrapolations. This plot is a simulation of the mean response for study 1102 predicted by the FDA model based on the information provided in the FDA briefing document. The blue and gray lines represent the bardoxolone and placebo predicted EGFR change respectively, and the observed mean data are shown by the black dots. The simulated values during the washout period at week 12 are higher than the observed values, suggesting overprediction of the acute pharmacodynamic washout because the model was built on data that included both acute and disease-modifying effects. Similarly, for study 801, the simulated values during the washout at week 8 are higher than the observed values. Taken together with study 1102, this suggests the FDA model does not accurately predict the observed acute EGFR washout. I'll now hand the presentation back to Dr. Meyer.
Thanks, Dr. Tusher. In summary, we respectfully disagree with the FDA regarding the adequacy of the off-treatment period. We have demonstrated that observed clinical EGFR data most reliably support the adequacy of the 28-day off-treatment duration. The 2-year design is an appropriate length to determine both the acute and chronic effects of the drug. The primary endpoint reflects the treatment effect in clinical practice, and the key secondary endpoints were included at FDA's request to assess for slowing the disease progression. I'll now discuss the clinical efficacy data. I will share the data demonstrating the effectiveness of bardoxolone in patients with Alport syndrome, including the pivotal study 1603 phase 3 results, as well as supportive data from study 1603 phase 2 and study 1803. The pivotal trial was a global multi-center study that enrolled patients at 48 sites in 6 countries. 2/3 of patients were enrolled in the U.S., and a central lab analyzed EGFR data for key efficacy endpoints. The evolving COVID-19 pandemic occurred during the last 9 months of the study and complicated study conduct. COVID-19 related measures were required to preserve patient safety and to maintain data collection in the study despite temporary site closures, travel restrictions, and logistical challenges. These measures included implementing home health visits, adjusting study visit schedules, and allowing flexibility in the week 100 and week 104 EGFR collection windows. We enrolled a population that was representative of the overall Alport syndrome population. Demographics were balanced between the two groups. We randomized 23 adolescent patients, representing approximately 15% of enrolled patients, and most patients had X-linked disease. The baseline characteristics were also representative of the overall Alport syndrome population and were balanced between treatment groups. Upon study entry, patients had impaired kidney function, even though the mean UACR was low. Most patients were receiving RAS inhibitor therapies, and blood pressure was well controlled. As shown in the bottom row of the table, the overall trial population was progressing at an average annual rate of eGFR decline of approximately 5 ml per minute. 157 patients were randomized into the ITT population. More discontinuations occurred in the bardoxolone arm than the placebo arm, primarily in the first year. After 48 weeks, 78% of patients randomized to bardoxolone remained on treatment compared to 89% of patients randomized to placebo. At week 100, roughly one-third of patients randomized to bardoxolone had discontinued study drug. Due to our efforts to maintain follow-up in the trial, once patients discontinued treatment, we obtained end-of-study follow-up at week 104 for 98% of all participants. The reasons for treatment discontinuation are shown on this slide. 26 patients randomized to bardoxolone and 13 patients randomized to placebo discontinued treatment during the 2-year trial. 10 patients randomized to bardoxolone discontinued due to adverse events, and no more than 2 patients discontinued due to any one type of adverse event. 7 bardoxolone-treated patients discontinued due to protocol-specified criteria, primarily due to management of aminotransferase increases, which were not associated with liver injury. I will now walk you through the analysis methodologies. The primary endpoints compare the effects of treatment after 48 or 100 weeks. We analyzed eGFR changes from the on-treatment periods using a mixed model repeated measures, or MMRM approach. The model included all eGFR values collected through 48 or 100 weeks, irrespective of study drug administration, and missing data were not imputed. The key secondary endpoints evaluated the off-treatment eGFR change following 1 or 2 years of treatment to assess for effects on kidney disease progression. Because these endpoints compared mean changes in eGFR at discrete time points, that is 4 weeks after stopping drug in year 1 or year 2, and ANCOVA was specified to compare changes from baseline in eGFR at 52 and 104 weeks, or 4 weeks after the last dose for patients who discontinued study drug. In this analysis, we imputed missing eGFR data based on the treatment group. Because the year 2 off-treatment analysis assesses the effect of long-term exposure, we pre-specified the analysis to only include patients who dosed in year 2. Patients who discontinued in year 1 after only short-term exposure to drug were excluded in the year 2 off-treatment analysis. This figure represents all eGFR values collected in study 1603 phase 3 through week 100. The columns represent the study weeks, and the rows represent individual patients. For the bardoxolone group, patients who had eGFR values collected while receiving treatment are shaded in dark blue, and eGFR values collected after treatment discontinuation are shaded in light blue. Since we followed intention to treat principles, the primary analyses included all available eGFR values collected over time, regardless of whether patients were receiving treatment or not. Missing eGFR observations are shown in the white cells, and missing data were not imputed. So, for example, at week 100, 84% of bardoxolone patients had eGFR values and 16% had missing eGFR observations. However, all patients had eGFR values collected throughout the 2-year study period that contributed to the primary efficacy endpoint. Study 1603 phase 3 met its primary endpoints with statistically significant and clinically meaningful improvements in eGFR relative to placebo. Treatment with bardoxolone resulted in a relative preservation of eGFR of 9.5 ml per minute at week 48 and 7.7 ml per minute at week 100 in the ITT population. To better characterize the response across all patients, we pre-specified a cumulative distribution analysis for changes in EGFR at week 100. Here we show the percentage of patients in each treatment group with the corresponding EGFR changes at week 100 denoted on the x-axis. Treatment with bardoxolone shifted the cumulative distribution of change from baseline in EGFR. Not surprisingly, most patients randomized to placebo experienced a worsening of kidney function. 90% of placebo-treated patients progressed more compared to bardoxolone-treated patients. Across the full spectrum of responses, a treatment benefit was observed with bardoxolone relative to placebo in the year 2 primary endpoint. We observed relative on-treatment EGFR improvements with bardoxolone at week 100 across all pre-specified subgroups, including age, sex, UACR and EGFR categories, ACE inhibitor and ARB use, and genetic subtypes. Similar results were observed for the key secondary off-treatment analysis. We conducted multiple sensitivity analyses to see how assumptions in the pre-specified analysis and any missing data could affect the primary efficacy conclusions. The pre-specified analysis model included a covariate that accounted for differences in treatment exposure for patients who discontinued drug early. While we realized the limitations of including a post-randomization factor, exclusion of this treatment duration covariate showed similar results for the primary endpoint. We also analyzed the primary endpoint using control-based multiple imputation. In this analysis, missing EGFR values in the bardoxolone group are imputed with placebo values. This analysis showed a similar, statistically significant treatment effect. Lastly, we used a simple ANCOVA analysis to evaluate EGFR change at week 100 and showed a treatment effect consistent with the year 2 primary endpoint results, demonstrating the study results were robust to various analytical methods. This figure shows all EGFR values collected over the 2-year study period. The key secondary analyses compared off-treatment EGFR changes after 1 or 2 years of treatment using ANCOVA. So in the year 2 key secondary endpoint, the off-treatment EGFR values included in the analysis are the ones highlighted in this column, light blue for bardoxolone and light gray for placebo. In the bardoxolone group, for patients that completed 100 weeks of treatment, these were the EGFR values collected at week 104. For patients that discontinued treatment early in year 2, these were EGFR values collected approximately 28 days after last dose. Together, 56 patients randomized to bardoxolone and 69 patients randomized to placebo had observed EGFR values that contributed to the year 2 key secondary endpoint. Missing EGFR observations for the year 2 key secondary analyses are shown in white cells, and missing values were imputed using treatment-based imputation in the ANCOVA model. This primarily includes patients who discontinued in year 1 and did not dose in year 2. Nevertheless, we continued to collect EGFR values for many of these patients, and despite being off drug for over a year, as you can see on the far right, we were able to collect EGFR values at the end of study for 96% of patients. The study met its key secondary off-treatment endpoints. After a 4-week off-treatment period, patients randomized to bardoxolone had a statistically significant preservation of EGFR compared to placebo at weeks 52 and 104. These data demonstrate that bardoxolone has a beneficial effect of slowing disease progression. Now, it's important to remember that based on the observed PK/PD profile of bardoxolone, we chose a target 4-week duration for the off-treatment period in the key secondary endpoints. As shown on this slide, we collected EGFR values over a range of days, from 14 to over 70 days post-dose. We analyzed the off-treatment EGFR values by weekly post-dose increments. We saw no association between the number of days post-dose and the magnitude of the off-treatment EGFR values for either treatment group. Off-treatment EGFR values collected in the earlier part of the analysis window in the left two columns were not higher than values that were collected later on the right. If the acute EGFR effect were still present during this period, we would see a negative trend over this duration, which was not observed. Importantly, we see here that the timing for collection of off-treatment EGFR values in study 1603 phase 3 did not affect the difference between treatment groups or impact interpretability of the study's key secondary efficacy results, demonstrating a slowing of disease progression. We also conducted several sensitivity analyses to probe the reliability of the key secondary results. In particular, we performed a tipping point analysis to see how missing data could have affected results. Bardoxolone patients with missing off-treatment EGFR values at week 104 would have had to have declined an average of 14 mil per minute from baseline. This decline would be unlikely. Still, we wanted to explore the likelihood of this happening. Again, the tipping point threshold required to lose significance, minus 14 mil per minute, is much lower than the mean EGFR changes in the bardoxolone or placebo arms, which were minus 4.5 and minus 8.8 mil per minute, respectively. Recall that data from patients who discontinued in year 1 were not included in the year 2 key secondary analyses. However, we actually obtained off-treatment EGFR data 4 weeks after the last dose for 16 of the 21 bardoxolone patients. All of the EGFR values in the bardoxolone arm would have had to have been below this red line for the results to lose significance. Their off-treatment EGFR values showed that did not happen. Finally, we performed additional sensitivity analyses that explored alternate analytical or imputation methods. As seen in this forest plot, all of these analyses showed similar treatment effects. The final analysis used all off-treatment EGFR values collected at the end of study as close to week 104 as possible. This included data from 96% of patients, including patients who discontinued in year 1, whose mean duration off study drug was 87 weeks, resulting in a dilution of the treatment effect. In some of these analyses, the treatment effect was not significant, but continued to favor bardoxolone, and confidence intervals overlapped with results of the pre-specified analysis. The consistency of the treatment effect across the collective sensitivity analyses supports the study's 1603 phase 3 conclusions in the key secondary endpoint. In regards to the impact of COVID-19 in the trial, the FDA noted in the briefing document that there was a difference in the EGFR change in the pre versus post-COVID periods. Only a small number of patients finished the trial in the pre-COVID era, making comparisons with that set of patients difficult. We noted that the bardoxolone-treated patients had similar treatment effects relative to baseline in both time periods, as highlighted on the slide. The apparent difference in treatment effect across COVID-era subgroups was therefore driven by the different rates of decline in the placebo group. We noted some imbalances in baseline characteristics between these two periods, which likely contributed to this, and the EGFR differences between these two periods do not affect the overall reliability or interpretability of the trial. We observed the largest treatment effect at weeks 100 and 104 in the adolescent subgroup. Adolescent patients treated with bardoxolone had statistically significant placebo-corrected improvements of 13.8 and 14.6 mol per minute at weeks 100 and 104 respectively, demonstrating slowing of disease progression in these patients with the greatest risk progression to kidney failure during their lifetimes. Whereas treatment with bardoxolone preserved kidney function, patients treated with placebo, shown here in gray, lost approximately 15 mil per minute by weeks 100 and 104. Given the mean baseline EGFR for these adolescents, the observed decline rate in the placebo group would translate to the need for dialysis or transplantation in approximately 5 to 7 years. During the trial, 2 adolescent patients randomized placebo, but none randomized bardoxolone, progressed to end-stage kidney disease. Here we see the trajectories of mean changes in EGFR over 2 years for the ITT population in study 1603. The gray line shows the placebo group, which showed progressive EGFR decline over the course of 2 years. The bardoxolone group is in dark blue. The trajectory for EGFR in year 1 shows some loss of acute EGFR effects, particularly between weeks 12 to 36. In year 2, the trajectory of EGFR beyond week 76 in the ITT population reflects, in part, the inclusion of patients who discontinued treatment. Still, we saw a meaningful separation between treatment groups after year 1 and year 2. To quantify how EGFR changes over time can translate to a divergence between bardoxolone and placebo patients, we performed an analysis to evaluate chronic EGFR slopes. Study 1603 phase 3 was not designed to evaluate a conventional slope analysis over 2 years, primarily through the treatment interruptions between year 1 and year 2. So we used a piecewise linear model to evaluate individual patient trajectories within each year. This showed a divergence between treatment groups when considering the chronic slope in year 2. Let's examine the area in this red box more closely. The year 2 chronic slope was minus 4.3 mil per minute per year for bardoxolone, compared to minus 5.8 mil per minute per year for placebo in the ITT population. This represents a slowing in the loss of kidney function of 1.5 mil per minute per year, which is also consistent with slowing disease progression. The divergence in chronic slope in year 2 is also supported by the EGFR trajectory observed through 3 years of treatment for patients in the open-label extension study 1803. These are the data for the patients with Alport syndrome who have had the longest duration of bardoxolone treatment, who are enrolled in studies 1603 phase 2 and 3 and continued in the open-label extension study 1803, which is ongoing. 19 patients have reached 3 total years of treatment with bardoxolone. The data for these patients over time show a pattern in year 1 and 2 that is similar to the bardoxolone group in study 1603 phase 3. Notably, the EGFR trajectory observed in year 2 continued in year 3, and these data demonstrate maintenance of a beneficial treatment effect through 3 years of treatment. This slide summarizes the totality of data evaluating rates of EGFR change. On the left, when we consider off-treatment EGFR analyses, the 2-year total off-treatment EGFR slope, which is an annualized extrapolation of the off-treatment year 2 key secondary endpoint, shows a slowing in the rate of EGFR loss of 49% per year. When we assess individual patients using all week 52 and week 104 off-treatment EGFR values in a longitudinal off-treatment analysis, we see a similar effect. On the right, the on-treatment chronic slope analyses in year 2 show a 25% reduction in the rate of kidney function loss in the ITT population. This effect is even larger in patients who remained on bardoxolone, the as-treated population, with a 34% slowing of disease progression. Reduction in the rate of disease progression with bardoxolone across these various analyses, both on and off treatment, show bardoxolone is effective in slowing the loss of kidney function in patients with Alport syndrome. Finally, we pre-specified an analysis of events in a kidney failure composite. Bardoxolone reduced the number of adverse kidney outcomes. We also surveyed how study patients felt when treated with bardoxolone. The blue bar shown here is a validated patient-reported outcome tool called the Patient Global Impression of Change. It is a 7-point scale that asks the patient how much their illness has improved or worsened. As you can see in the table below the scale, in addition to significant improvements in EGFR relative to placebo, treatment with bardoxolone also significantly improved how patients felt. In summary, study 1603 phase 3 met its year 1 and year 2 primary and key secondary results. The magnitude of these effects were clinically meaningful, both on and off treatment. Our EGFR slope-based analyses, both on and off treatment, demonstrated a slowing of disease progression with bardoxolone treatment, indicating these treatment benefits will be maintained over time. In conclusion, these data provide substantial evidence of efficacy that bardoxolone slows the progression of CKD in Alport syndrome. Multiple sensitivity analyses demonstrated consistency of the results. These benefits were observed on top of standard of care, and the results are generalizable to the Alport syndrome population. 2 additional Alport syndrome studies showed consistent results while also providing evidence that bardoxolone can preserve kidney function for up to 3 years. These results represent a clinically meaningful benefit in adults and adolescents with this rapidly progressive form of CKD. Turning now to safety. I'll now present the key safety data from pivotal study 1603 phase 3. I will cover the relevant safety information for bardoxolone, including adverse events from our Alport syndrome development program, special safety topics of interest, our key safety elements of our proposed label, and our pharmacovigilance plan. Bardoxolone has a comprehensive safety data set from trials that enrolled more than 3,000 patients with over 2,200 patients exposed, and the safety profile is well characterized. Prior CKD experience informed risk mitigation strategies implemented in the Alport syndrome development program. To avoid heart failure previously observed in Study 903, in all trials conducted since 2012, we narrowed eligibility criteria and increased monitoring during the first few weeks of treatment. In addition to more frequent monitoring, we implemented flexible dose titration to accommodate differences in individual patient tolerability. Bardoxolone's safety profile in Alport syndrome was generally consistent with the prior trials. The overall adverse event profile for the pivotal study 1603 phase 3 was similar across adults, adolescents, and other subpopulations. There were no deaths, and there were no fluid overload or cardiac serious adverse events in the bardoxolone-treated patients. The majority of AEs were mild or moderate in intensity and tended to occur within the first 12 weeks. The number of patients who reported an SAE in the bardoxolone group was approximately 1/2 that reported in the placebo group, and no SAEs were reported in adolescent patients treated with bardoxolone. Discontinuations due to adverse events were higher in the bardoxolone group, and no more than 2 patients discontinued due to any one adverse event. These are the commonly reported adverse events with bardoxolone. Those highlighted in blue are those that we've identified as adverse drug reactions and are included in the proposed label. Several of the ADRs and common AEs have been well characterized and will be discussed as safety topics of interest. Fewer bardoxolone-treated patients reported an SAE compared to placebo. SAEs reported by 2 or more patients are shown in this table, including kidney failure events, which were balanced across treatment groups. Overall, there were no imbalances in SAEs. Symptoms of Alport syndrome are not just limited to the kidney and often include depression and anxiety, as well as hearing and vision disturbances. These non-kidney manifestations affect patients' daily lives even before they reach kidney failure. Adverse events for all of these categories were reported less frequently in bardoxolone-treated patients. With over 2,200 patients with various types of CKD exposed to bardoxolone in trials, we've observed several common adverse events. We've divided them into areas of clinical interest shown here. I'll first cover the most frequently reported adverse events. Some adverse events are hypothesized to be related to the pharmacological effects of bardoxolone, as I'll explain. NRF2 regulates multiple pathways, and many observed clinical findings with bardoxolone may be explained, at least in part, by the presumed mechanism of action. Muscle spasms are the most common AE reported with bardoxolone. They were mostly mild to moderate in severity and not associated with increases in creatine kinase or other evidence of muscle injury. They typically present as lower extremity muscle cramps, similar to a Charlie horse. Flexible dose titration helped to resolve them, and only 2 patients discontinued. Hyperkalemia events were all mild or moderate in severity, and nearly all events were reported in patients receiving concomitant ACE inhibitors or ARBs. Hyperkalemia is a known side effect of this class of drugs. None of the events were serious or resulted in study drug discontinuation. Although increased albumin in the urine, as assessed by UACR, can be a marker of injury, bardoxolone's pharmacological effect on EGFR can also increase UACR in a manner that differs from disease progression or injury. The combined effects of increasing filtration rate and decreasing albumin reabsorption explain the increases in albumin excretion seen with bardoxolone. We have shown in non-clinical studies that increases in single nephron GFR are not associated with increased intraglomerular pressure and do not affect glomerular permeability to albumin, demonstrating the integrity of the filtration barrier remains unchanged. Additionally, we have also shown that bardoxolone decreases the expression of megalin, the primary protein involved in albumin reabsorption in the proximal tubules. This plot shows UACR over time. Consistent with prior trials of patients with pre-existing albuminuria, treatment with bardoxolone increased UACR in patients with Alport syndrome. After an early increase that is accounted for by the increases in EGFR, UACR generally remains stable through 2 years of treatment. The stabilization of UACR while continuing treatment and its return to baseline after 2 years of treatment and withdrawal of drug is not consistent with glomerular damage. Injury to the glomerular filtration barrier would be expected to cause a continued increase in UACR over time that does not return to baseline or placebo after withdrawal, which was not observed. Importantly, the increases in UACR are not associated with accelerated EGFR loss. We analyzed patients by quartiles of UACR change at week 12, shown in the middle column, and assessed EGFR changes on and off treatment after 2 years in the right 2 columns. The quartile of bardoxolone-treated patients with the largest UACR increases at week 12 had the largest on treatment and off treatment EGFR changes relative to the other quartiles of bardoxolone-treated patients and all placebo quartiles after 2 years of treatment. These data are consistent with a UACR profile that is due to the drug's pharmacologic effect and is opposite of a pattern of injury. Small but reversible increases in BNP were seen with bardoxolone treatment, with mean values remaining below the upper limit of normal. Importantly, the increases in BNP were not associated with blood pressure elevations or fluid overload adverse events. Overall, fewer cardiac adverse events were reported in the bardoxolone group compared to the placebo group. Blood pressure was unchanged relative to placebo through 2 years in study 1603 phase 3. Moreover, in a thorough QT study in healthy volunteers at doses up to 80 milligrams, we have shown that bardoxolone does not affect blood pressure. As mentioned earlier, we saw an increase in heart failure events in study 903 and associated increases in blood pressure, including 24-hour ambulatory blood pressure monitoring that was assessed in a subset of patients. After study 903, we implemented risk mitigation across all trials, and in a trial of patients with pulmonary hypertension, we conducted 24-hour ambulatory blood pressure monitoring, as shown on the right. In this trial, we saw no increases in blood pressure, supporting that a risk mitigation strategy could be effective. Prior to initiation of our Alport syndrome program, our Japanese partner reinitiated clinical development in patients with diabetic kidney disease. In their phase 2 402-005 study, they implemented the risk mitigation plan we developed and carefully monitored patients during the 16-week trial. Weekly serial troponins were assessed and showed no elevations. Additionally, no adverse findings were observed in serial echoes, and blood pressure remained stable without evidence of heart failure. This study was instrumental in supporting our reinitiation of development in CKD. Across all CKD studies conducted after Study 903 that have exposed more than 600 patients and implemented these risk mitigation strategies, we have not observed any cardiac SAEs. Further, we have not observed any mean elevations of blood pressure, and the number of exposed patients is meaningfully greater than the bardoxolone arm in Study 1603 Phase 3. These data provide evidence that the risk of severe fluid overload requiring hospitalization, as well as less severe manifestations, such as increases in blood pressure, can be mitigated. Regarding weight loss, non-clinical models of diabetes and obesity have shown that bardoxolone and its analogs reduce total body fat content and preserve lean muscle mass. And these effects are mediated by NRF2-dependent changes in lipid metabolism and fatty acid oxidation. In clinical studies, decreases in body weight with bardoxolone were accompanied by reductions in waist circumference without changes in total 24-hour excretion of urinary creatinine, consistent with loss of fat and not muscle. Patients randomized to bardoxolone experienced weight loss relative to baseline and placebo, which is consistent with prior trials. This plot shows weight changes by baseline BMI subgroups, with the patients randomized to bardoxolone with higher BMI shown in white squares and lower BMI in blue squares. Decreases in weight were more pronounced in patients with higher BMI. Mean changes in body weight were minimal in adolescent bardoxolone-treated patients who generally continued along their growth curves for both height and weight. We have shown in multiple non-clinical studies that NRF2 activation regulates ALT and AST production in multiple organs, and the clinical profile of aminotransferase increases in Study 1603 is consistent with pharmacological induction of gene expression rather than injury. FDA's review also came to similar conclusions. Here on the left, we see the profile of ALT over time. These increases peaked approximately 2 weeks after patients reached their final dose, were transient, with mean values trending back down while patients continued treatment, and the increases were also reversible and returned to baseline in the 2 off-treatment periods. Importantly, these increases were associated with reductions in total bilirubin, as seen on the right, and across all studies, there were no cases of Hy's law. We are collecting longer-term data in Study 1803, an open-label extension study. This study has enrolled 96 patients and has demonstrated no new safety signals with up to 3 years of treatment. There have been no treatment-related serious adverse events reported to date, supporting longer-term safety with bardoxolone. Based on the safety findings, we have proposed careful monitoring. Because the Study 903 in patients with diabetic CKD was discontinued due to excess heart failure events in patients treated with bardoxolone, we contraindicated use in patients with a history of heart failure. Also, in the warnings and precautions section, we instruct physicians to assess BMP prior to treatment initiation and to monitor for sudden weight gain and other signs and symptoms of fluid retention, which may precede CHF, in accordance with the American Heart Association heart failure guidelines. Treatment should be discontinued if patients develop CHF. Aminotransferases should be assessed prior to treatment initiation and during the first 3 months of use. Patients should discontinue the drug if large increases in aminotransferases or parameters consistent with Hy's law are observed, with frequent monitoring until resolution and before rechallenge. Finally, weight should be monitored if unexplained or clinically significant weight loss occurs. Patients should discontinue drug and be evaluated. proposed pharmacovigilance plan also includes expedited reporting of post-marketing cases of liver impairment, as well as severe cases of CHF and unexplained weight loss leading to BMI of less than 18.5, risk communication and education in a medication guide. We proposed a post-marketing registry to follow at least 500 patients for 5 years, providing additional safety data and select efficacy outcomes. Finally, we have outlined a pediatric study in patients with Alport syndrome aged 8 and above as part of our European pediatric plan commitment. In conclusion, bardoxolone has a well-characterized and manageable safety profile in patients with Alport syndrome. AEs are generally mild to moderate in severity, reversible with treatment discontinuation, and not life-threatening. Fewer SAEs were observed in bardoxolone treated patients compared to placebo, and there were no deaths. There were no increases in blood pressure, no imbalances in AEs associated with fluid status, and no SAEs for heart failure in patients randomized to bardoxolone. In the ongoing longer-term study 1803, we've observed no new safety signals. The data demonstrate a similar AE profile across adults, adolescents, and other subpopulations. Across our entire safety database, we've observed no cardiovascular safety signals in studies conducted after study 903. Further, we have characterized the profile of UACR changes, which is not consistent with kidney injury. Overall, the safety data from the Alport Syndrome Development Program is consistent with and supported by our comprehensive safety database and a conservative proposed label and monitoring plan. I'll now introduce Dr. Glenn Churchow, who will present the benefit risk assessment for bardoxolone in Alport syndrome.
Thank you, Dr. Meyer. My name is Glenn Churchow. I am a professor of medicine and by courtesy professor of epidemiology and population health and former chief of the Division of Nephrology at Stanford University School of Medicine. I have been treating adult patients with Alport syndrome for nearly 30 years. I was the steering committee co-chair and site investigator of the Beacon trial. I will provide a benefit risk assessment of the use of bardoxolone in treating patients with Alport syndrome. I am a consultant to Reata and I've been compensated for my time. I have no financial interest in the outcome of this meeting. We begin from a place of great medical need. Alport syndrome typically leads to rapidly progressive chronic kidney disease and a high risk of kidney failure in a generally young patient population. There are few existing therapies known to be of benefit. These are limited to the angiotensin-converting enzyme inhibitors and angiotensin receptor blockers. Although ACE inhibitors and ARBs are effective at slowing progression of chronic kidney disease, they do not generally prevent or arrest progression. Most patients will progress to kidney failure, albeit slower than they might have otherwise. We know that delaying the progression of chronic kidney disease to kidney failure not only forestalls the need for transplantation or dialysis, but can preserve functional capacity and, importantly, health-related quality of life. The National Kidney Foundation, together with the FDA and EMA, showed that a difference of even 1 or 2 ml per minute per year, if sustained, could result in extended dialysis and transplant-free survival. The data demonstrate a number of clinical benefits with bardoxolone, a therapy with a novel mechanism of action. We recognize that the mechanism of bardoxolone is unique among approved agents or agents being evaluated in chronic kidney disease. We have become accustomed to the narrative that kidney function inexorably declines. We have not seen other agents that increase kidney function acutely and preserve kidney function chronically. In study 1603, we saw preservation of kidney function, that is higher eGFR, on treatment, and sustained benefits off treatment. The changes in estimated GFR compared to placebo were not only statistically significant, but also clinically meaningful. Bardoxolone was safe and efficacious in adults as well as in adolescents. I should point out, of course, that in this clinical trial aimed to evaluate disease-modifying effects, the study drug was discontinued. However, in clinical practice, we tend not to interrupt therapy in this way. Rather, if patients are faring well, we continue therapy. Importantly, we have seen that the benefits of bardoxolone were sustained over 3 years. The observed benefit with bardoxolone and the magnitude of the effects on eGFR, both on and off treatment, should translate to a beneficial effect on delaying disease progression. Based on the starting eGFR for trial participants and the rates of progression of eGFR seen in study 1603, even using the more conservative off-treatment estimate annualized from the year 2 key secondary endpoint, again, if sustained, the effect of bardoxolone could translate into a multi-year delay in time to kidney failure. For patients who remained on treatment, this effect could be more profound. This has additional benefits when one considers the severe shortfall in deceased donor organs. In my region of the country, waiting times exceed the life expectancy of nearly all older patients requiring dialysis, approximately 10 years. And for younger patients, like those with Alport syndrome, delaying progression might mean the difference between a single preemptive kidney transplant lasting throughout middle age or beyond, and the need for 2 or more kidney transplants and the need to start or restart dialysis. We must evaluate the risks of bardoxolone in the Alport syndrome population, which were not serious or life-threatening and were clinically manageable. Elevations in the aminotransferases were generally observed within the first 8 to 12 weeks, transient in nature, and not accompanied by increases in total bilirubin or clinical evidence of liver injury. Muscle spasms, which have been seen consistently in studies with bardoxolone, are rarely severe and often wane over the course of several weeks. There was a decrease in body weight, which was proportional to the baseline BMI. In other words, obese adult patients tend to lose more body weight than non-obese patients. Adolescents treated with bardoxolone appear to maintain their individual growth curves. While albuminuria tends to increase early in the course of bardoxolone treatment, the increase is not sustained and is proportional to the rise in eGFR. In the pivotal 1603 phase 3 study and all CKD studies conducted after Beacon, there were no increases in mean systolic or diastolic blood pressure, serious cardiovascular events, or deaths. Monitoring patients with Alport syndrome for these and any other potential adverse effects is feasible in nephrology practices. Adult and pediatric nephrologists typically serve as either the primary or principal care physician for patients with Alport syndrome. We evaluate blood pressure and volume status at every follow-up visit for these patients. We routinely measure laboratory data, including assessments of liver enzymes and total bilirubin, as well as kidney function and electrolytes. We also commonly measure UACR or UPCR, the urine protein to creatinine ratio, to monitor progression of disease in response to therapies, including ACE inhibitors or ARBs. The frequency of clinic visits increases as chronic kidney disease advances to stages 3B, 4, and 5. In early stage Alport syndrome, at least on the adult side where I practice, we might see a patient once or twice a year, whereas patients with more advanced disease are typically seen every 2 to 3 months. In summary, bardoxolone offers the potential to sustain kidney function and reduce the progression of kidney disease for several years without requiring either dialysis or kidney transplantation, as suggested by the on-treatment as well as the off-treatment effects. Balanced against the potential risks, which are clinically manageable, it is my clinical perspective that the benefits of bardoxolone outweigh the risks and offer a much-needed therapy to patients with Alport syndrome and the physicians who treat them. I'll now turn the presentation back to Dr. Meyer, who will provide concluding remarks.
Thank you, Dr. Chertow. Bardoxolone offers a novel and effective approach to treating patients with Alport syndrome who have high risk of progression to kidney failure, often at a young age. We have demonstrated through multiple analyses that bardoxolone slows the progression of kidney disease in patients with Alport syndrome, and the treatment effect, both on and off treatment, is large and clinically meaningful. We as the sponsor are committed to the Alport syndrome community and to the safe use of bardoxolone for a post-approval registry, risk management plans, and documentation of long-term outcomes. We hope to work with the agency to bring the first treatment option to
Now, remember your name, if for the record, before you speak, and direct your question to a specific presenter if you can. If you wish for a specific slide to be displayed, please let us know the slide number if possible. Finally, it would be helpful to acknowledge the end of your question with a thank you, and the end of your follow-up question with, that is all for my questions, so we can move on to the panel member. I'm going to begin. First question, if the sponsor could please bring up slide C17. In a orphan drug application, which has often a surrogate outcome, in this case one that there's some controversy about, the totality of data is important. And so the preclinical data and the mechanism of action and hypothesis are very important. I have several questions about slides conclusions. I have read all the references listed under the slide, and I think a couple others that were not in the briefing document. My first question revolves, and this would be a yes or no answer. In the diabetic study that was on Beacon, there were no diabetic animal model studies done prior. SOLA, which is listed here as 2010, in 2013, unfortunately, after the Beacon trial was and almost stopped, did a diabetic rat study which showed loss of weight, increased blood pressure, increased albuminuria, glomerulosclerosis, and increased LFTs. I was unable to locate any use of bardoxolone in one of the animal models of Alports. So my first question is, was such a study done, and if so, could you share the data? Secondly, a claim is made that there is no effect on intraglomerular pressure. The DANG 2013 reference shows an increase in filtration fraction with no change in reasonable plasma flow. The most evidence-based explanation for that would be an increase in intraglomerular pressure, which would be associated with an increase in albuminuria. A definitive study to decide what is really happening in the glomerulus, and obviously intraglomerular pressure increases, as the sponsor has acknowledged, are bad, would be a micropuncture study, or micropuncture studies done with bardoxolone. Thirdly, the hypothesis, which is novel, that there's a increase in glomerular surface area. I was unable to find any other examples of any drug that did increase in glomerular surface area or intervention of any sort, or that was associated with a benefit. So if there is such a thing, please share with the committee. And lastly, I'm unaware of examples of drugs that cause an increase in albuminuria but that have been demonstrated to show a benefit in chronic kidney disease. And if there's an example, could you please share with the committee? So I guess that's 4 quick questions. Please keep to yes, no, or as short as you can.
Thank you, Dr. Lewis. We acknowledge that the mechanism is novel, and while we have not conducted studies of bardoxolone in models of Alport syndrome, we have conducted numerous studies in other chronic models demonstrating anti-fibrotic effects.
It's okay, just yes or no. No, it's fine. No, it's fine. I'm sorry. I'm just trying to, we're late. Go ahead.
We have not done micropuncture, but we've done 2 photon laser microscopy. And we are unaware of other drugs that have been shown to increase the surface area.
Okay, thank you. And lastly, drugs that increase albuminuria but have been demonstrated to preserve kidney function.
We are unaware, but note that the profile is unique and different than agents that are associated with injury or disease progression.
Thank you. Then I think the first person with the question is Dr. Pawlewski. Dr. Pawlewski, please unmute.
Thank you. I was in the process of unmuting as you asked. Dr. Paul Pawlewski. Maybe I missed it, but I did not see a description of methodology for EGFR calculation and whether it was based entirely on serum creatinine or whether you used other established markers such as cystatin C. My one reason for concern is the associated weight loss, and it would be important to know whether there's any data on change in creatinine generation associated with the weight loss that occurs over time. My third question relates on slide CE22, which is the plot of the EGFR change. And I note that when drug is reinstituted after week 52, the increase in EGFR from the off-drug period appears to be substantially less than at year one, which raises concern that the pharmacodynamic effect of the drug had not worn off over those 4 weeks. Can you please address that issue? Thank you.
Yes, I heard several questions from you. I'll first start by addressing your question about assessment of kidney function. We acknowledge that it's important to accurately assess kidney function. And slide up. Prior to our initiation of our Alport syndrome trial, our Japanese partner conducted a phase 2 study, placebo-controlled over 16 weeks duration in patients with diabetic CKD. And as shown on the left, there was an increase in inulin clearance, so obviously independent of serum creatinine, and that change was correlated with the change in estimated GFR per creatinine-based assessments. Furthermore, on the right, in that same study, they collected 24-hour urines to demonstrate that there was no change in excretion of 24-hour urines. We've also demonstrated that in 3 other trials. In regards to how it was calculated in the Alport syndrome trial.
Before you go on with that, with regard to that, so you said that's 16 week rather than a more prolonged course of 48 weeks where there may have been more weight loss and therefore more change in creatinine generation. Do you have data at a 48-week time point?
No, we do not have data at a 48-week time point, but we have it at 16 weeks here and other time frames that show no evidence of any changes in excretion of creatinine. So to answer your question directly about EGFR assessment, in the Alport syndrome trial, CKD epi was used for adults and bedside-Schwartz equation was used for kids.
But there are multiple CKD epi equations. You just use the creatinine-only equation.
That is correct.
Do you have data on cystatin C?
No, cystatin C was not collected. And then to address your question about weight, if we can slide up. As I mentioned earlier in the presentation, we did see weight loss in the study, and it was dependent upon baseline BMI. Shown here is the EGFR change stratified by those subgroups. And you can see that at the very end of the trial, there's very similar EGFR change despite the large differences in weight for these patients. And so demonstrating that the change in serum creatinine is different than the change in weight. And then to address your question about washout, if we could pull up the scatter plot, the week 50 or the week 104 data. So on the left here, this is all EGFR values that contributed to the key secondary analysis. And on the slide on the right is all except these 4 outliers. And so Dr. Tusher, can you please comment on this?
Nathan Tusher. After the washout, there's no continuing change in EGFR after day 14. It's a very flat, even though wide distribution of data. We could go back to CE22 also, which was the original question. It's important to note that there is disease progression. The difference between the peak of the bardoxolone treated and the peak or in the same time point for placebo is quite similar, even though it doesn't look like the rise is as much. So what you can see is that the bardoxolone is providing already at year 1 some benefit, and then that distance between placebo is maintained once treatment reinitiates.
Thank you.
Dr. Mertz?
Thank you, Dr. Noel Barry Mertz. This is a question for Dr. Meyer. If we could go to slide C6. It demonstrates 2 bardoxolone subjects progressed to end-stage kidney disease compared to 0 in placebo. If you read the fine print, however, there were 3 patients in placebo that progressed and an additional one in the active arm. I presume that they went on to dialysis or kidney transplant. How do you handle intention to treat in that situation, as well as the imputation? What were the strategies to mitigate this problem? Thank you.
Dr. Chen, can you please address the question?
Melanie Chin, Reata Pharmaceutical. In the intention to treat analyses, we included all EGFR values collected up until the point the patient discontinued from the study due to reaching end-stage kidney disease. For the analysis of the primary endpoint, we did not impute for missing data.
Thank you.
Dr. Medley?
Thank you. This is Susan Mendley. Dr. Myers, on slide CS20, you stated that adolescent patients generally continued along their baseline growth curves for height and weight. But when I reviewed the Reata provided briefing materials on page 155, section 9.9, section figure 54, I note that at least 3 and perhaps 4 of the adolescent males had failure of age-appropriate weight gain such that they fell off their growth curve and crossed 2 or more percentile lines, generally considered a pathologic growth pattern. Can you provide any data to this committee to reassure us or patients or parents that this pattern of failure to gain weight in a normal fashion does not increase the risk of stunting in a population already at risk for growth failure? Thank you.
If we recognize the limitations of the small data set and are committed to collecting additional data in the post-marketing setting and recommend careful guidance, I'd like to have Dr. Brad Wardy specifically comment on these data and to address your questions.
Brad Wardy, slide up, please. So as mentioned, there were some crossing of lines in the adolescents on bardoxolone, not dissimilar from what occurred in the placebo population. I think it's important to recognize that when one looks at the bardoxolone patients, again, who were small in number, that their average height at baseline was already 171 centimeters, and their average weight was 65 kilos. These individuals, who were a mean age of 15 years, were in large part fully grown. Next slide up, please. And then this is the data for the adolescents on bardoxolone to look at their weight over the course of the study. And you can see for the most part, their weights were maintained, and they did not demonstrate significant weight loss, which was seen in some of the adult individuals who had very high BMIs. So again, this is something that would clearly need to be monitored long-term in patients who are treated like we do for all CKD patients who are followed up in the clinics.
Thank you. Would everyone please put their hands down who have had their questions answered? And our next panel member with a question is Dr. Butler.
Thank you very much. This is a question for Dr. Myers, slide CE11. Realizing that smaller numbers makes interpretation difficult, but I was just wondering if you can comment on your interpretation of baseline eGFR and whether there's a trend of less benefit with advanced lower GFR.
We would expect that patients with a lower GFR and more irreversible loss of kidney function would have a smaller treatment effect. So when we kind of account for the baseline GFR, the relative change is closer, but yes, there is a less treatment effect. We do note, however, that it still favors bardoxolone, and I'd like Dr. Chertow to comment on this treatment effect.
Thank you, Glenn Chertow. I would just say that the treatment effect is clinically meaningful in both groups. Thank you.
Thank you. Dr. O'Connor. And please remember to state your... Thank you, Dr. O'Connor. Everybody remember to state their name first.
Dr. Christopher O'Connor here, and this is a question for Dr. Tusher. And the slide that corresponds to figure 32, page 96 of the briefing document regarding the natriuretic peptide levels. Thank you for taking a serious mitigation effort for the current trial, the Cardinal trial, after showing an increase in heart failure in the Beacon trial. And while we have normal natriuretic peptide levels at baseline, if you could pull that slide up that corresponds to figure 32, it appears that the drug actually increases natriuretic peptide levels within this intranormal range, which also has important prognostic significance in sort of preclinical heart failure and other cardiovascular disease. And then during the washout, the natriuretic peptide level comes down. You reinstitute the drug, it elevates again, and washout, it comes back down. Are you familiar with animal studies that have shown that this class of drug could have direct myocardial injury effects? And second question is, was there any asymmetric post-randomization withdrawal of RAS inhibition between the treatment and placebo group?
To answer your second question first, there is no evidence of asymmetric withdrawal of RAS inhibition. To answer your first question, slide up. We do have direct evidence from animal studies with a close bardoxolone analog that demonstrate that there is increased BMP expression that's associated with reduced cardiac hypertrophy. This is consistent with the metabolic effects that BMP has beyond the effects on fluid. Slide up. And we actually see differential expression or BMP levels in the Alport syndrome phase 3 trial. Shown here are BMP levels by baseline BMI subgroup. So in the patients who had higher BMI, who lost more weight, we saw larger increases in BMP. I'd like to have Dr. Bangalore comment on the clinical profile of BMP that we saw in our Alport syndrome trial.
Hi, Shripal Bangalore, interventional cardiologist, NYU Medical Center. I'm a paid consultant for Rihanna Pharmaceuticals, and I have no financial interest in the outcome of the meeting. And I think it is important to clearly differentiate Beacon from the Alport syndrome patients who are much younger, and their BNP profile at baseline was significantly lower than that of Beacon. And I think that being said, given the fact that these patients will be on these medications for a long time, and some of them may develop the profile similar to Beacon, the risk medication measures outlined, close monitoring of fluid status, blood pressure, monitoring for any elevation in blood pressure, and close monitoring of heart failure, I think should maximize the benefit and at the same time decreasing the risks of these patients.
Thank you. Dr. O'Connor, does that answer your question? I think we'll move on to Dr. Nuckman.
Yes, thank you, Patrick Nuckman. I have a couple of questions regarding the patient population that was included in the phase 3 trial. And particularly, I did not see either in the briefing material or today's presentation any analysis based on genotype. Riata made a big point, very important point, that patients who are either X-linked hemizygous males or have autosomal recessive disease have a significantly higher risk of progressing to ESKD. But I have not seen analysis based on this. I know that the analysis has been made for adolescents versus not. I did not see the exact number of patients who are males with X-linked or male or female with autosomal recessive. So that's question number one, and that pertains to Dr. Butler's question from before. Again, most of the benefit seems to be related to patients who start with a well-preserved GFR and minimal albuminuria. So the two questions are interrelated. And my third comment, if I may, pertains to slide CE11, which seems to correspond to the Riata briefing material figure 19, but the two are not exactly the same. There are some significant differences in the reported benefits and confidence intervals between the two. And if you could comment on why the two are so different, specifically for patients with UACR more than 300, for X-linked Alport syndrome, and for low GFR. Thank you.
Thank you for your questions. I'll address your question about X-linked versus non-X-linked. So shown here on this slide, CE11, this is the forest plot of data from the primary endpoint at week 100, so the on-treatment analysis. And you see that there's clinically meaningful effects in the X-linked patients and the non-X-linked patients. Overall, there are 23 male X-linked patients in the bardoxolone group and 21 male X-linked patients in the placebo group. And then I believe that you're referring to the BV38 slide up. This is a similar forest plot, but this is for the key secondary week 104 analysis. And so once patients had withdrawn drug, and we still see a clinically meaningful treatment effect in the X-linked as well as the non-X-linked patients. And we recognize that there is a larger treatment effect in patients with earlier stage disease, but these patients progress very rapidly, as highlighted in the pediatric patients. And so in our view, it's optimal to get to them before they have too much irreversible loss of kidney function that bardoxolone could not affect.
Thank you. Did that answer all your questions, Dr. Nuckman? We'll go on to Mr. Paul. Dr. Nuckman, are you, yes?
Yes, thank you.
We'll go on to Mr. Paula Conway.
Thank you, Doctor. My question is actually for Dr. Meyer. In looking at the FDA briefing materials under the appendices 6.1, page 39, I was a little bit intrigued about the back and forth that had occurred with FDA, and I'm interested in your perspective on, or some clarification on why the company chose not to engage with FDA at the end of the second trial, because there appears to be, based on the footnote number 2 there, a fair amount of correspondence back and forth on EGFR. And I'm just interested in your own language, your description of that.
Yes, and so we had numerous interactions with the division about multiple CKD programs in this time frame. I think that provides helpful context. In 2016, in our pre-IND meeting, we actually proposed a phase 2 study for our Alport syndrome study. And in the meeting, the division recommended a phase 2-3 approach that included a 2-year treatment duration and 2 off-treatment periods. I was present at that meeting. We engaged in dialogue with the division as collaborative. And in the end, they acknowledged our design. We submitted our protocol to the division. In our study may proceed letter, they noted that the week 104 endpoint following a 4-week drug treatment withdrawal period would be critical for evaluating efficacy and supporting approval. And as I was mentioning in my presentation, we had a parallel program in polycystic kidney disease where we engaged with FDA for an end of phase 2 meeting in February of 2019. And this was approximately a year and a half into enrollment of the pivotal phase 3 Alport syndrome trial. And we had a same basically proposal for the design, 2 years in total treatment duration, 2 off treatment periods with a 28-day window. And in that meeting, individuals in the meeting at FDA inquired about the sufficiency of the off-treatment period. And so we specifically discussed the 28-day topic. We reviewed data, much of the same data that Dr. Tusha reviewed. And then we submitted it to them as they requested, and they said they were reassured by that data. They then, a few months later, asked for an end of phase 2 meeting for Alport syndrome. And so once again, a year and a half into the conduct of the phase 3 trial, we had just discussed the design, and we thought we had addressed all of FDA's comments. And we didn't discuss the Alport syndrome trial again until after we reviewed the year 1 data with them. And so just to clarify, there was a lot of back and forth. We were listening to FDA, and we incorporated all recommendations from them into our trial.
Thank you. That answers my question.
Thank you.
Arms. And then the second question, in your briefing documents, you talk about the effect of bardoxolone on regulation of expression of megalin, which is involved in proximal tubular protein reabsorption. Do you have any data to inform us as to whether the changes in proteinuria are due to increases in glomerular protein leak or a change in tubular reabsorption? Thank you.
This is Dr. Meyer, and to address your first question quickly, no patients within the Alport syndrome trial were using concomitant SGLT2 inhibitors. Regarding your second question, we've performed many non-clinical studies to probe the effects on proteinuria. Clinically, it's hard to differentiate between the increases in GFR and the megalin contribution. but we do see both effects experimentally. We do see that associated with increases in single nephron GFR using 2-photon laser microscopy, that there is not an increase in permeability in wild-type animals or animals with diabetic kidney disease. I think most importantly, clinically, we see return to baseline in the 2 off-treatment periods. And I'd like to highlight the pediatric albuminuria data. Despite the limitations of a small N, we actually did see progression in the placebo-treated adolescent patients. Slide up. So while in the adults there was no progression, it's a relatively flat line. Here, this is only the adolescents, gray or placebo-treated. Over the course of 2 years, you can actually see about a doubling of proteinuria. With the bardoxolone-treated adolescent patients, we actually see some variability, slight increases early, but by the end of the trial, albuminuria is actually lower in the bardoxolone-treated adolescent patients. And so this perhaps is the best way to interrogate in patients who have the most fragile kidneys, the most severely rapid disease, if bardoxolone would have any adverse effects on albuminuria and kidney function in the clinical setting. And in, obviously, the EGFR-based data, this subgroup had one of the largest between-group differences showing preservation of kidney function.
Thank you. I have a quick question. Do you have a slide of the magnitude of the acute effect based on the baseline EGFR? And while you look for that slide, I'd like to let Dr. O'Connor to ask his question. And Mr. Conway, I think you want to put your hand on.
Yeah, this is Dr. O'Connor. This is Dr. O'Connor. Quick question. Was there any concern by the Data Safety Monitoring Board throughout the trial with some of the emerging adverse safety signals, particularly around the liver function studies, the UHC, the BNP, and did the Data Safety Monitoring Board agree with the interim analysis and breaking the blind to present to the FDA a potential expedited review?
So the data monitoring committee that oversaw the trial on an unblinded basis had obviously access to the insights that we've generated and data supporting the profile of LFTs as well as BNP. They did specifically look for any changes that were outside of the pharmacologic profile that we've observed, such as actual cases of liver failure or emergence of fluid-related heart failure, which was not seen, and there were no concerns raised during the conduct of the trial. The FDA proposed the study design, which included a 1-year off-treatment period that could support accelerated approval. And so that was pre-specified in the protocol in the statistical analysis plan. And we had a specific data access plan that limited the number of people who had access to the information. And so that was prospectively defined, shared with the data monitoring committee, as well as the FDA.
Dr. O'Connor, quickly, could you send us the minutes from the DMC?
Are you requesting it from us, the sponsor?
I assume that you have the minutes of the DMC now that the trial's over.
Yes, and we provided that all minutes to the FDA in our NDA.
Okay, then we can get it from the FDA. Thank you.
Do you have the slide of the magnitude of the acute effect based on EGFR available yet? If not, you could do it over the lunch break.
I have that available.
And we have one last. Oh, great. If you just show it, thanks.
You can see here the dark blue shaded squares on top are the patients who had baseline EGFR of greater than 60, and those patients that had baseline EGFRs of less than or equal to 60 are shown in the open squares, and those patients tend to have a slightly lower acute increases.
Big. Nachman, our last question. Dr. Nachman, do you want to unmute?
Yes. Sorry, I muted myself by mistake. Patrick Nachman again. I would like to come back to this baseline EGFR and baseline albuminuria issue and figure 19 on page 64 and slide CE11. So I stand corrected from my previous comment that one is off treatment and one is on treatment. But especially when you look at the off treatment, it looks like the benefit of bardoxolone in patients with a GFR of 60 or less than 60 is not existent. And for patients with a UACR of 300 or more, the benefit is small and the confidence intervals cross the zero line. So my question is, does the sponsor think that there is going to be is there a GFR or a proteinuria level at which you think that treatment is not beneficial? And if so, what would it be? I mean, looking at looking at figure 19, it looks like there's really very little benefit if the GFR is below 60 or if there's substantial proteinuria.
Yes, we note that there is a smaller treatment effect in patients with lower GFR. We also note that there's a meaningful treatment effect in patients with high albuminuria at baseline, so patients who progress fairly rapidly. And we also acknowledge that due to this relatively small trial in a rare disease, it's hard to make firm conclusions about subgroup analyses. We did have a post hoc finding in patients with low GFR that it appeared that many of those patients were not at their goal dose. And when patients are at their goal dose, those patients tend to have a better treatment effect. Slide up. And so to illustrate this point in just the overall population, goal dose versus not goal dose, the gray line is placebo. The patients who were at their goal dose at the end of the trial are in blue, at top, dark blue. And
corresponding sensitivity analysis. As discussed by Dr. Johannesson on the prior regulatory device, the most appropriate outcome to assess is an off-treatment EGFR analysis based on EGFR values collected after any acute PD effect has resolved. Thus, we will focus on the year 2 off-treatment analysis, year 2 off-treatment endpoint in this section. The year 2 off-treatment endpoint is changed from baseline in EGFR at week 104. This endpoint achieved statistical significance with the least square mean difference of 4.4 and p-value of 0.02. However, this analysis is based on observed data from 80% of the patients, excluding a substantial amount of actual observed data. As shown in the second row, 20% patients were excluded from the analysis in total. The exclusion rate is unbalanced between the two arms. Percentage of patients excluded in bardoxolone almost doubles that in placebo arm. Among these excluded patients, 25 patients were excluded because they discontinued treatment permanently in year 1 and did not take any dose in year 2. These patients had available off-treatment EGFR values collected, but the data were not used in the analysis. They were considered as missing and were imputed under the missing at random assumption. That being said, the imputation considers them as if they would perform similarly as the patients in the same treatment arm who continued the study treatment to year 2. The inclusion-exclusion of the data used in this analysis was based on the applicant's defined analysis window, which will be further explained in the next slide. Here is the applicant's definition of the week 104 off-treatment analysis window, defined as at least 14 days after last dose in year 2. Two issues related to this analysis window definition that we think are critical are listed here. Firstly, the last dose in year 2 in this definition excluded the 25 patients who discontinued treatment before year 2. As mentioned, these patients had available observed off-treatment EGFR values. Secondly, the study was designed with a 4-week, 28 days washout period. However, the analysis window used a 14-day cutoff value, meaning that the off-treatment EGFR values in the analysis could have been collected between 14 days and 28 days after last dose, which was before the 4-week washout period ends. The next 3 slides provide more information for these 2 issues. For the first issue related to the analysis window, the excluded 25 patients were explained in this bar chart. The left 2 bars in the gray box show that 25 patients discontinued treatment permanently in year 1. Note that the number of patients discontinued treatment in year 1 is unbalanced between the 2 arms, 16 in bardoxolone versus 9 in placebo. All of these 25 patients had available off-treatment EGFR values collected at least 14 days after last dose. 22 of them stayed in the trial until the end of year 2 and had EGFR values collected at follow-up visits. These 25 patients did not take any dose in year 2, thus were excluded from from the pre-specified year 2 off-treatment analysis. The right two bars show the 125 patients continued to be treated through year 2. We call them year 2 dosed patients for simplicity. Most of these year 2 dose patients discontinued treatment at week 100. All of these patients took at least one dose in year 2. And these were the patients whose off-treatment EGFR observations were included in the pre-specified year 2 off-treatment analysis. In total, this bar chart shows all 150 patients with available off-treatment EGFR values regardless of treatment discontinuation, which consists of 96% of all randomized patients. We call these 150 patients all available patients. Because one of the keys to reduce bias in randomized clinical trials is randomization, stay as close as possible to all randomized patients reflects the intention to treat principle, which minimizes bias. So the review team considers it important to analyze all available patients instead of just these year 2 dosed patients. When the 25 patients were excluded, the patients used in the analysis may no longer be a good representation of all randomized patients. Thus, the analysis between groups is not randomized comparison anymore and may introduce bias. For the second issue related to the analysis window, a 14-day cutoff was used for a 4-week washout. As discussed earlier by Dr. Johannesson on the adequacy of the 4-week washout period, it is not clear if a 4-week, 28-day washout was long enough for the reversible PD effect on EGFR to be fully resolved. The applicant defined analysis window used a 14-day cutoff to collect off-treatment EGFR values, resulting in an even shorter washout period of 2 weeks. The EGFR values collected within this with this 14-day cutoff includes values collected between 14 days and 28 days after last dose. These EGFR values were possibly collected before the PD effect on EGFR has fully resolved, which could potentially bias the comparison in favor of Padoxil. Let me further illustrate the groups of patients with off-treatment EGFR values collected using the pre-specified 14-day cutoff versus a 4-week, 28-day cutoff. This bar chart shows all 150 available patients with off-treatment of the EGFR values collected at least 14 days after last dose. To the left of this solid black line are the patients with off-treatment EGFR values collected less than 28 days after last dose. To the right are the 111 patients with off-treatment EGFR values collected at least 28 days after last dose, which consists of 71% of all randomized patients. So not all patients had full 4-week washout period before their off-treatment EGFR values were collected because of the visit window definition. Analyses on these 111 patients using a 28-day cutoff are more likely to rule out the potential bias caused by the PD effect on EGFR. Therefore, the agency requested some sensitivity analysis in addition to the pre-specified sensitivity analysis for the year 2 off-treatment endpoint The pre-specified sensitivity analysis only included the year 2 dose patients, but did not include the observed off-treatment EGFR values for those 25 patients who discontinued treatment in year 1. And those analyses mainly focus on assessing the missing data assumption. The agency requested sensitivity analysis took into consideration of the off-treatment EGFR data collected from all available patients instead of using only year 2 dosed patients. So it took into consideration of those 25 patients who discontinued early but stayed in the trial to preserve the integrity of the randomization under the intention to treat principle. The agency requested sensitivity analysis also focus on assessing the impact of analysis window by performing analysis to compare treatment effects between using the 14-day cutoff and the 28-day cutoff. The results are shown in the next 2 slides. The first set of sensitivity analysis were performed on year 2 dosed patients. Just for comparison, the results of the main pre-specified year 2 off-treatment analysis is included in the first row. As a reminder, by the definition of the analysis window, the main analysis used a 14-day cutoff to collect off-treatment EGFR values. And the excluded observations were imputed by assuming the patients who discontinued treatment in year 1 or lost to follow-up behaved similarly as the available year 2 dosed patients in the same treatment arm. The first sensitivity analysis was an observed case analysis performed on the same set of patients as main analysis without imputation. This analysis includes 80% of all randomized patients. Because the pre-specified year 2 off-treatment analysis imputes data under the assumption that the excluded patients behave similarly as those year 2 dose patients, the treatment effect in the observed case analysis is similar to that of the main analysis. The second sensitivity analysis used a 28-day cutoff. Patients with EGFR values collected between 14 days and 28 days after last dose were excluded. Results show that the treatment effect becomes smaller when the 28-day cutoff is used. Note, this analysis used observations from only 55% of all randomized patients. Within these 2 sensitivity analyses, we consider the second sensitivity analysis with 28-day cutoff provides a better estimate of the true treatment effect, since this analysis is more likely to rule out the PD effect. The second set of sensitivity analyses were performed on all available patients, regardless of treatment discontinuation. Similarly, we included the results of the main analysis in the first row for comparison. The sensitivity analyses were also performed without imputation. The first sensitivity analysis used all 150 patients with available earliest off-treatment EGFR values collected at least 14 days after last dose. This consists of 96% of all randomized patients and reflects the intention to treat principle. Results show that the treatment difference becomes smaller when all available patients were used. The second sensitivity analysis used the 28-day cutoff and included 111 patients with eGFR values collected at least 28 days after last dose. This consists of 71% of all randomized patients, as can be seen from the result. If all available patients, regardless of taking a dose in year 2 or not, were considered, and use only off-treatment eGFR measured at least 28 days after last dose, the treatment difference is 0.8, almost disappeared compared to the main analysis. In this set of two sensitivity analyses, the first analysis is based on intention to treat principle and better estimates the true treatment effect than the main analysis. The second analysis used a 28-day cutoff based on all available patients, although some patients were excluded. Results from this analysis is more likely to rule out the bias from unresolved PD effect. From these 4 agency-requested sensitivity analyses, we can see that when including only the eGFR values collected at least 28 days after last dose, the treatment difference becomes smaller. And when all available patients were considered, regardless of treatment discontinuation, the treatment difference becomes smaller or almost disappear. Note, for each patient discontinued treatment early, multiple off-treatment eGFR values could have been collected. For example, in this figure, if a patient discontinued treatment at week 24, the first eGFR value could have been collected at or around 28 days after treatment discontinuation. And the last eGFR value could have been collected at or around 104 weeks after randomization at the follow-up visit. The 4 sensitivity analyses shown above used the change from baseline to their first off-treatment eGFR values. If the last off-treatment eGFR values collected at or around week 104 were used, the treatment differences shown in the above table are smaller or becomes negative. In summary, the results from the agency-requested sensitivity analysis provide more information from the data collected. The results show that if the 28-day cutoff is used for the analysis window, treatment effect becomes smaller. If the 28-day cutoff is used, and when data from all available patients were taken into consideration, treatment effect almost disappeared. However, there are limitations on these agency-requested sensitivity analysis. These analyses are all observed case analyses, and some of them excluded a considerable number of patients. These analyses should be considered as exploratory only, but not conclusive. Thank you. And now let me turn it back to Dr. Johannesson.
Dr. Shaw. Next, I'll present an overview of the safety database and all safety findings. The experience in 157 pages, the safety evaluation focused on the Cardinal Phase 3 study, which included 157 patients with Alport syndrome, and is supplemented by Beacon, a Phase 3 study, which included 2,185 patients with stage 4 CKD and type 2 diabetes. Notably, Beacon was terminated early due to a numerical imbalance of all-cause mortality and higher rates of fluid overload-related serious adverse events, including heart failure in the bardoxolone arm. In Cardinal phase 3, there were no deaths and concerning imbalances in serious adverse events. There are more discontinuations reported in the bardoxolone group for increases in liver enzymes, BNP or NT-proBNP, and acute kidney injury based on pooling of related adverse events using customized medical query. Adverse reactions observed with bardoxolone in Cardinal and Beacon are shown in the figure for bardoxolone in blue and placebo in gray. Each bar represents the percentage of patients reporting the event. In general, the adverse event profile is similar between Cardinal and Beacon, with some notable exceptions. There are no heart failure events in Cardinal and no imbalances in the percent of patients reporting peripheral edema. Cardinal was designed to exclude patients with risk factors associated with heart failure, such as patients with elevated BNP at baseline and patients with prior hospitalization for heart failure event. More patients in Cardinal reported elevated NT-proBNP or BNP levels. In Beacon, however, BNP levels were not routinely monitored while on treatment and were collected at week 24 in a subset of patients. More patients in Cardinal reported elevated liver enzymes, which I'll discuss more on the next slide. Bardoxolone also caused changes in a variety of laboratory parameters and vital signs. Increases were observed for NT-proBNP, BNP, liver enzymes, urinary albumin-creatinine ratio, or USCR, ferritin, albumin, serum potassium, and blood pressure. Decreases were observed for serum magnesium, creatinine kinase, hematocrit, hemoglobin, and body weight. The mechanism of these observed changes are not understood. Bardoxolone also caused an increase for the liver enzymes AST and ALT. The increase in these liver enzymes did not coincide with an increase in bilirubin, and no high loss cases were observed. The increase in liver enzymes subsided with continued dosing and resolved during the washout, suggesting the possibility of enzyme induction without significant liver injury. Next, I want to discuss the risk of heart failure with bardoxolone. Although there were no heart failure events in Cardinal, heart failure remains an important safety issue, and heart failure was observed in the Beacon study. Beacon was designed to determine if bardoxolone was effective at delaying the progression to end-stage renal disease in patients with an eGFR between 15 and 30 ml/min type 2 diabetes. Heart failure occurred within the first 4 weeks after randomization with a statistically significant hazard ratio of 1.8. BNP was not routinely measured during the Beacon trial, but there was substantial elevation in BNP at week 24. Cardinal phase 3 was designed to exclude patients with high risk for heart failure based on the findings of Beacon. Were excluded with a history of heart failure hospitalization, cardiac disease, elevated baseline BNP greater than 200. Furthermore, patients with eGFR less than 30 ml/min were excluded. By enrolling patients with low risk for heart failure, there are still increases in NT-proBNP and BNP with bardoxolone treatment. Not clear if a lack of heart failure events in Cardinal is generalizable to the patient population with Alport syndrome who will be taking bardoxolone. Next few slides discuss the observed increases in albuminuria and blood pressure with bardoxolone. Both Cardinal phase 3 and Beacon, bardoxolone increased albuminuria as measured by urinary albumin-creatinine ratio, or USCR. Increase in albuminuria is associated with adverse kidney and cardiac outcomes. The figure shows the time course of the USCR for bardoxolone in blue and placebo in gray. During both years, there is an increase in USCR relative to baseline and placebo, and USCR decreased during the washout period as indicated by the shaded areas. USCR was observed in pediatric patients and patients with baseline USCR below and above 300 milligrams per gram. The observed increase in albuminuria raised concern about potential adverse effects on long-term kidney function. Bardoxolone has been shown to increase blood pressure. Drugs that cause sustained increases in blood pressure, even small increases in blood pressure, are associated with adverse cardiovascular effects. The FDA recommends ambulatory blood pressure monitoring, or ABPM, to detect small but clinically meaningful increases in blood pressure that can be missed with blood pressure measurements. Ambulatory blood pressure monitoring study was conducted in a subset of patients in Beacon, and the study showed that bardoxolone increased systolic blood pressure by a mean of 5 mm mercury, which was larger than what was detected with clinic blood pressure measurements. There was no clear signal for blood pressure increase in Cardinal. However, the absence of a signal based on clinic blood pressure measurements does not provide reassurance that bardoxolone does not increase blood pressure in patients with Alport syndrome because the lack of blood pressure detection could be due to the blood pressure measurement methodology used in Cardinal. Last safety issue that I want to discuss relates to the observed decrease in weight. Body weight was observed in Cardinal and Beacon. The figure on the right shows the time course in weight for bardoxolone in blue and placebo in gray for Cardinal based on the safety population. The mean decrease in weight were apparent by week 6, continued through week 12, and tended to plateau after week 12. The mechanism for the weight loss is not well understood. Pediatrics on this slide, I'm showing the time course of weight in pediatric patients. You can see that an increase in weight in the placebo subgroup, the gray line, relative to baseline, and no change in weight in the bardoxolone subgroup, the blue line. It's difficult to draw definitive conclusions about weight changes in pediatrics because the size of the pediatric subgroup is small. 11 patients in the bardoxolone group and 12 patients in the placebo. Any treatment group differences in body weight raise concerns about the impact of bardoxolone on the growth and development in pediatric patients. Lastly, I want to discuss the benefit-risk assessment for bardoxolone. The FDA review team recognizes that Alport syndrome is a rare, serious condition with an unmet need and no approved therapies. However, for the reasons discussed in this presentation, the FDA review team does not believe the submitted data demonstrate that bardoxolone is effective in slowing the loss of kidney function in Alport syndrome. The review team does not believe bardoxolone has been shown to have clinical benefit. Bardoxolone causes changes in a variety of laboratory parameters and vital signs and increase the risk of heart failure in Beacon in a different patient population or advanced kidney disease. Mechanism underlying these changes is unclear. Patients raise concern for safety and long-term efficacy. Cardinal excluded patients with severe chronic kidney disease, eGFR less than 30 ml/min, who are more proximate to kidney failure. In principle, a treatment that causes a large fixed increase in eGFR that persists on treatment could delay initiation of dialysis in a population proximate to dialysis. However, the rationale for starting such a therapy at earlier stage of disease is unclear. Moreover, whether such a strategy is effective and results in a benefit that outweighs the risks would need to be prospectively studied in a target population. FDA review team working on this application are shown on this slide. Thank you for your attention.
Thank you. And I appreciate that you went under time as well. We will now take clarifying questions for FDA. Please use the raise hand icon to indicate that you have a question. And remember to lower your hand by clicking the raise hand icon again after you've asked your question. When acknowledged, please remember to state your name for the record before you speak and direct your question to a specific presenter if you can. If you wish for a specific slide to be displayed, please let us know the slide number if possible. Finally, it would be helpful to acknowledge the end of your question with a thank you. Your follow-up question with that is all for my questions. so we can move on to the next panel member. My first question is with Dr. O'Connor.
Thank you, Dr. O'Connor. This is a question for Dr. Zhao on slide 25. Thank you for performing these important sensitivity analysis. Would it be fair to say that while the point estimates are lower in your sensitivity analysis from the pre-specified sponsor main analyses, the point estimate that you found, which is lower, is really not significantly different than the main analysis findings, given that they fall within the confidence intervals of the main analysis point estimate? Thank you. That's the end of my question.
Hi, thanks. This is Eliza Thompson, and I'm just going to be moderating the questions for FDA. So we will certainly direct this one to Dolly. Dolly, can you respond?
Yes. Hi, this is Dolly, the statistical reviewer. So in our in slide 25, the sensitivity analysis with 28-day cutoff excluded some patients, more patients than the main analysis, and it provided at least a square mean difference of 2.6 versus a 4.4. It is smaller, but we did not compare these two analyses using any formal test or anything, so we cannot say it is significantly smaller than that 4.4, but just want to use this exploratory analysis to show the AC committee about the result when using the 28-day cutoff.
But it falls within the confidence interval, so would that mean that it's within the expected fluctuation from the main analysis? Thank you.
Dolly, can you address that?
I don't know.
And this is Eliza Thompson. Just to, and maybe you are in fact asking a different question, but I think the purpose of some of these analyses were, as well to explore, the time window being used and whether it was sufficient. But I'll stop as well.
Thank you. Mr. Conway? Dr. O'Connor, please. Thank you. Go ahead, Mr. Conway.
Okay. Thank you very much, Chair. My question's also on slide 25, and at the top I'd say thank you to the FDA for including reference on pages 9 and 10 of your briefing document about the NKF and Alport Syndrome Foundation session that was held and the patient insights, obviously, that were revealed in that. But on slide 25, and looking at it, I understand this is exploratory analysis, but the figure of 2.8, I'm wondering how would you describe that to a patient that has Alport syndrome? What is that data basically saying to that patient who's looking at this trial and listening to this today? What does that data show?
Great. And if we could please show this slide for all to see. And I apologize. We may need to take a minute pause. It looks like some of our members may be disconnected. Some of us also aren't seeing a display of slides, so I think maybe having a little bit of a challenge here.
While you take that minute, I will make a comment. So I'm very involved with many of these endpoint suggestions, and there are numerous references to that in the sponsor's briefing document. For example, the 0.75 mils per year benefit is if it's a consistent effect. would be fair to say, unless a consistent effect over time is plausible or shown by the data, a 2 mil difference in GFR would not be clinically significant or meaningful to a patient. And
Dr. Lewis,
close. Go ahead. Do you have your slide, Dr. Thompson?
Yeah, I think we now have our slide up and our other members on the team. Maybe I can offer some comments from a clinical perspective, and then also just want to note, Dr. Lewis, that we have another statistician who can respond to a prior question. So if we can revisit that question as well at some point, that would be great. In terms of, just maybe to take a step back, I just want to speak to how we think about GFR decline as a surrogate endpoint. If you think about it, typically in our trials, the size of the treatment effect in terms of the absolute size that we see in a trial can be very small. And so our assumption about whether that 2 mil per minute per year difference will translate into a clinically meaningful effect on progression to kidney failure assumes that treatment effect will continue to accrue over time across the various stages of the disease. So the curves continue to diverge over time. That's the concept behind it. So, just looking at one time point and noting two differences, that doesn't necessarily tell you in what you need to understand is whether that's continuing to accrue over time across the various stages of disease. Does that answer your question, or do you need additional clarification?
No, that answers it. Thank you.
And Dr. Lewis
and Dr. Thompson,
go ahead.
Yeah, I do.
I apologize. Jalu, can you respond to the earlier question?
Hi, this is Jalu Down from the FDA statistician from Office of Biostatistics. Can you hear me?
Yes.
Okay. So,
I'm sorry. There's been an internal error. You will be disconnected now. Goodbye.
Can you still hear me?
Yes.
Yeah.
Okay. I hear a message that it's disconnected. Okay. Getting back to the earlier question, I believe the question was in the main analysis, the estimate is 4.4 with a confidence interval 0.7 to 8.1, and then one of our sensitivity analysis using the 28-day cutoff showed the point estimate of 2.6, whether we would consider the two are different. So let me just clarify, the confidence interval of 0.7 to 8.1 measures the uncertainty for the estimate of that 4.4 in the main analysis. We are not able to do a formal comparison in terms of how this sensitivity analysis, the point estimate, how that would be differ from the 4.4. So like Dr. Zhou said, this is just to provide some additional information in terms of the point estimate, in the sense that it gives you a sense of the magnitude of the treatment effect. The confidence interval of each estimate provides the uncertainty around that estimate. I hope that clarified the question.
Yes, it does.
Dr. Mertz?
Thank you, Noel, very much. I have a similar question as prior for Dr. Zhao. Again, on slide 26. We were told in the morning that they had 94% follow-up status of all participants for their intention to treat. And so my question is, in your all subjects used, how were the end-stage chronic kidney disease participants, were they included or not? They would have been on dialysis or received a transplant. Thank you.
Dolly, can you please address?
Yes. So I suggest you refer to the analysis with 14-day cutoff. That includes 150 patients. And I didn't check if they're on patients are on dialysis or end of stage renal disease, but for these 150 patients, they had this EGFR values collected for them are used in this analysis are the earliest EGFR values after their last after 14 days after their last dose. So it's not necessarily at the end of study, but it could be close to the last dose, could be close to the time when they stop the study treatment.
Thank you. I would suggest that we should know that. Thank you.
May I help with that a little bit? So there are not very many ESRD events, so I'm not sure it's going to impact much, but often you could use an EGFR of less than 15 as a value for someone who went on dialysis if you didn't have approximate in time close value. Did either your analysis do that for the ESRD patients?
Dolly, can you address? If not, Jalu?
I think I can. I haven't done that analysis. But did you refer to the composite endpoint that the sponsor provided earlier this morning, or another, something different?
I think the composite endpoint is wow, I hear music. Somebody must have put us on hold. Yeah. The composite endpoint is like different. It includes three things, but one way to handle, if you're doing a GFR analysis, people who like kind of crash into dialysis or whatever, and you don't have a recent GFR that's less than 15, is to assume anyone on dialysis has a GFR less than 15. I bet you didn't do that, and I bet the sponsor didn't either, but I've just asked it. And I think that's what Dr. how you used ESRD, how you counted them for GFR. I'll let you think about it, I just for time's sake, because I think I might be confusing you more than I'm helping you. Dr. Palveski? Oh, can you guys hear me? Oh, cool. Great.
So, given all of the questions about whether the pharmacodynamic effect wears off within the 4 weeks, one other way to look at outcomes would be to do a slope analysis of the data on treatment. The sponsor did discuss the slope analysis, but it was limited to the year 2 data. Has the FDA looked at this and looked at an analysis of slope incorporating both year 1 and year 2 data? Beyond treatment data?
Thanks. Dolly, do you want to answer this? And Lars, do you have any comments?
Yes, this is Dolly, statistical reviewer. I think I can first answer this first, and if anyone had additional comments. we can answer it maybe later. So due to the study design, with the washout period at end of year 1, patients were put off treatment during week 48 and then to week 52. The conventional total EGFR slope analysis over the 2 years is not appropriate.
Although, could you do an analysis censoring the data from the week 48 to week 52 when the medication was restarted? Since the pharmacodynamic effect one would expect would be fully reversible in both directions.
And Dolly, please feel free to respond. I believe Lars may also have some additional comments.
Okay. So firstly, an adequate estimate of the slope could provide some information about treatment effect. However, because of the trial design, the patients were off treatment for 4 weeks. It's not clear that PD effect will affect how it affect the estimate, and it's not clear if the the piecewise linear mixed effect model is a robust and unbiased estimator of the second-year chronic slope. There are some unknown factors like the change point should be pre-specified for that analysis. And importantly, with the unignorable and the unbalanced recent data, result would be hard to interpret. So the patients available in year 2 is not a good representation of all randomized patients anymore. And if you only use those patients that have year 2 measurements, this is not a randomized comparison anymore.
What about just looking at one comparisons?
And maybe just to jump in for a second, Dolly, perhaps we could have Lars comment?
Yes.
Lars?
Last sentence in clinical analyst. Can you hear me?
Yes.
Thank you. So I had some audio issues on my end. So I'm just going to try and go to slide 16. Oh, sorry, that's a bit of a lag, Caroline. See if I can get to slide 16. So analysis looking at the slope over time across all the data was included in the PKP model. When we included an interaction or tested for a difference in the rate of decline between treatment arms in the model, which considers all the data across both years, we do not see a difference between the 2 treatment arms. And I'm showing you here on slide 16, which I hope you can see now, both the observed and the model predicted data. We see what also visually looks like the slope is fairly similar between treatment arms, which is what the models indicated as well. I hope this addresses the question.
May I make a comment while you have up actually on page 71 of the briefing document of the sponsor, they state that the slope is actually worse than placebo between weeks 12 and 36 of the first year. So after the supposed PD effect and before the washout. I don't know if you want to confirm that or not. I will say slope analysis with this number of patients is probably a super reliable thing, but did you look at the first year and did you confirm what the sponsor said on page 71 about the first year?
Dolly or Lars, can you comment?
This is Dolly. I didn't look at this year 1. I don't know if Jialu knows if there is a result.
Hi, this is Jialu Zhang. We have not confirmed that year 1 slope analysis. In essence, we don't believe such slope model is helpful in a sense based on the data and the design of the study.
Thank you. Dr. Palvetsky, did we get at your answers? And I will refer you to page 71 of the briefing document so you can at least see what they said.
That's actually the data on page 71 was what prompted my asking the FDA if they had looked at this.
Okay, thank you. Good. Dr. Butler.
Thank you, Dr. Lewis. This is Javed Butler. Do we know whether the natriuretic peptide elevation signal was largely limited to those with eGFR less than 60 or was seen in both groups? Thank you.
Lars, can you answer that question?
Lars Johansson, clinical analyst in the I did not do that analysis.
Okay, thank you.
Well, remarkably, I again want to thank the FDA for getting us back on time. We are, if there are no further questions, I'm getting typed a message. Oh, Dr. Nachman, I see your hand is up. We will take your question.
I have a question, but maybe not to the FDA, and I don't know if this is the right time to ask it.
I will, well, it is the right time, and since we have a few minutes, I will allow the question to the sponsor to make their answer brief, please.
Patrick Zuckman again. I'm having a little bit of a hard time wrapping my brain around the concept that, you know, a lot of the discussion we're having is whether the effect of the study drug is purely a pharmacodynamic / hemodynamic effect, as opposed to an effect of the drug on inflammation, on fibrosis, and on the hypothesized increased in glomerular surface area. And the question that I have is, if we think that this is an effect on what's going on in the kidney from the fibrosis or inflammation or surface area level, would we expect such a big washout effect in 14 days or 28 days? It seems to me that we're using different arguments for different things, and that they're not completely aligned with each other. That's the end of my question. So maybe our glomerular experts or Liata experts could comment on that, or Dr. Lewis.
This is Colin Meyer. I'd be happy to respond. So there are two distinct effects with bardoxolone. In animal models, we've demonstrated that the acute increases are due to effects on surface area. We can't prove that in humans, but showing the slide here from FDA 16, those initial increases we believe are that effect. An effect on fibrosis would take months and months and months to accrue. I'd like to point out that the time to peak here is exacerbated by the titration schemes. In all of our modeling, we see a direct relationship for the acute effects to plasma levels. And so the acute effect is manifest within 2 weeks of patients reaching their final dose. And then when patients wash out the drug, that effect is lost. And so yes, it is a large effect. And based upon the rate of progression of patients in the Alport syndrome trial, which is about 4.5 mil per minute per year, with a slowing of progression of 50%, which is a very large slowing of progression, that's still only a few mil per minute accumulation of the chronic effects over time. And so all of our data are consistent with demonstrating that the drug is washed out within 14 days, which is why we justified the window the way we did.
Does Does that answer your question, Dr. Nuckman?
In part.
I think our comments to each other about it will be in when we get to the questions from the FDA, if that's okay. And then I think that'll be the more appropriate time for me to comment. Okay? All right. We will now break for lunch. We will reconvene at 2:15 p.m. Eastern Time. Panel members, please remember that there should be no chatting or discussion of the meeting topics with other panel members during the lunch break. Additionally, you should plan to join at around 2 p.m. to ensure, as we learned this morning is very important, you are connected before we reconvene at 2:15 p.m. Thank you. We will now begin the open public hearing session. Both the FDA and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, FDA believes that it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written and oral statement to advise the committee of any relationship that you may have with the applicant, its product, and if known, its direct competitors. For example, this financial information may include the applicant's payment of your travel, lodging, or other expenses in connection with your participation in the meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking. The FDA and this committee place great importance in the open public hearing process. The insights and comments provided can help the agency and this committee in their consideration of the issues before them. That said, in many instances and for many topics, there will be a variety of opinions. One of our goals for today is for this open public hearing to be conducted in a fair and open way where every participant is listened to carefully and treated with dignity, courtesy, and respect. Therefore, please speak only when recognized by the chairperson, and thank you for your cooperation. We have a large number of speakers today. Each will be limited to 3 minutes. I apologize in advance. To be fair, I will stick to the clock. So if I interrupt you, again, my apologies, but it is only fair to stick to the clock. Speaker number 1, your audio is connected now. Will speaker number 1 begin and introduce yourself? Please state your name, the organization you may represent for the record.
Hi, my name is Afton DeLuca. I don't represent a specific organization, just myself and my family. I have no financial relationships with any party associated with this hearing. As I said, my name is Afton DeLuca. I'm from Madison, Alabama. I'm an Alport syndrome patient and the mother of an Alport syndrome patient, my 6-year-old son, Cameron. Alport syndrome has impacted multiple generations of my family, including my grandmother, 2 of my uncles, my mother, myself, and my son. I have overcome a lot of misinformation and bias as a female with Alport syndrome. Before finding a nephrologist who suspected that I was experiencing more than a UTI, my family was told that women were not affected by this disease. They are simply carriers. This belief is misinformed at best, and at worst, life-threatening. While I'm empowered by the information I've gained through my diagnosis, the knowledge that I live with a condition that could rapidly worsen at any time and has no curative treatment has caused me both anxiety and depression at times. Distress is further compounded by the fact that many of my doctors have never treated a patient with Alport syndrome before, having only read about it in medical textbooks. Consequently, many of the physicians have not taken the possibility of disease progression or the need for preventative treatment options seriously in my case. In addition to advocating for my own health, I'm also relentlessly focused on making sure my son gets the best possible care. In my experience, the treatment protocols for children are often just as misunderstood as those for adults. I believe that the approval of an Alport-specific treatment option would increase physician awareness of this rare disease and provide them with a safe and effective treatment to offer their Alport patients. Approval would also mean that my son has the opportunity to manage his condition with an effective oral medication instead of invasive procedures like dialysis and kidney transplant that both of my uncles endured throughout their 20s. It could potentially buy him years or even decades of help that his great-uncles didn't have. The approval of bardoxolone would offer our family a chance to free ourselves from a legacy of organ failure at a time when Cameron, representing the youngest generation of my family, should be focused on finding his place in the world instead of finding a new kidney and bearing the burden of a new disease, a lifetime of organ rejection medicines, being permanently immunocompromised, and always worrying about losing the organ.
With those additional years of health, Cameron would continue to pursue his love of basketball, writing science fiction stories, and American Ninja Warrior training to the best of his abilities. Approval would give me hope for the future, both as a patient and as a mother. Thank you for your time and the chance to share my family story.
Thank you. Speaker number 2, your audio is connected now. Will speaker number 2 begin and introduce yourself? Please state your name and any organization you are representing for the record.
My name is Lisa Bonebrake. I have no financial relationships to disclose. I'm 55 years old and have X-linked Alport syndrome. I'm the parent of 2 young men. It's my youngest son, age 19, who inherited my genetic mutation for Alport syndrome. As a tween and teen, Alport syndrome swiftly took away my son's identity, self-confidence, and quality of life. Doctors emphasized the only way to slow disease progression was for Grant to take ACE and/or ARB medications. Though his blood pressure was naturally very low, the increasing doses of these standard of care medications complicated his life at every turn. He took ice packs to school and tried to hide them under his shirt to keep himself cool enough not to get dizzy. If he stood up too fast or exerted a bit of energy playing a game or sports, he would crawl to the grass or someplace safe to pass out. It was a daily challenge for him to wake up. The fatigue was constant. Due to illness, fatigue, and stress, Grant missed school so often that at one point he spoke of how our family would be better off if he was no longer on this earth. To him, at age 14, life was far too hard and without enough joy. Because these medications were not making a difference in his lab results and were affecting his quality of life, we were motivated to seek out a clinical trial. Grant and I began the Cardinal study on the same day together 4 years ago. Within several months, Grant's lab results improved enough that the PI asked how he felt about taking Grant off his ACE medication. His blood pressure was so low it was dangerous for his other organs, let alone that frequent passing out. The change was almost immediate. He started feeling stronger, less tired and stressed, and able to be physically active. His outlook and emotional health improved significantly. For us, participating in this study has been about time. It gave Grant time to get through his high school feeling well, keep up with his peers, get into an excellent college. After 4 years of feeling good on the study, really good, Grant's labs began to be concerning this past August. End-stage renal failure came within 3 months. He began dialysis 2 weeks ago. His older brother has stepped forward to be his living donor. Transplant surgery is imminent. But during those 4 years, Grant became stronger, and so did his brother, now older than 18 and able to be willing and a qualified donor. I continue to do well on the study, and I'm hopeful that I won't spend my retirement years on dialysis. The study has also given me time to be strong enough to get my kids off to college and to now work full-time in a very meaningful job, helping other families with Alport syndrome. As Alport families await novel therapies and potential genetic cure, so many are suffering and deserve an alternative to the standard of care, which often is not tolerated or barely tolerated. There are other therapies currently being studied. Perhaps bardoxolone will be a complement to them or a bridge. My family believes that other families should have access to bardoxolone to give them time as well. In fact, I wish I had more time today. There is so much more to say.
Thank you.
Thank you.
Thank you. Speaker number 3, your audio is connected now. Will speaker number 3 begin and introduce yourself? Please state your name and any organization you are representing for the record.
My name is Shari Lara. I am a patient. I have participated in the study, been paid a stipend and reimbursed for my travel. I live in the rural area of Lander, Wyoming. My brother and I were diagnosed with Alport syndrome in the 70s, inherited from my mother. My brother was a pioneer in kidney research under Dr. Tom Starzl. He lived on the 7th floor of the Colorado Medical Center during these studies. My brother's first transplant was at the age of 13 by Dr. Starzl. This transplant lasted about 13 years. His second transplant lasted until his death in 2016. My sister, dad, and I lived in Wyoming, and my mom and my brother had to live in Denver during this time. I still don't know how my parents could have afforded to run 2 households with only my dad working during this time. We would drive to Denver every Friday night after my dad got off work to spend the weekend with my mom and Tim. When Tim had to go on peritoneal dialysis, my parents were trained on how to operate this machine. We had to run dialysis on Tim at our home in Wyoming since there were no dialysis units available. We recently found a journal that my brother had kept during this time of his life. His writings were very detailed about the emotions that he had during this time. He was very grateful for the research that Dr. Starzl did for this disease. He would write that he knew when Dr. Starzl would come around late in the evenings as there would be cigarette butts in his toilet. I would never have participated in a clinical study like the Cardinal trial with an investigational drug if it hadn't been for my brother. My brother would have participated in this study without a thought. He knew what he'd lived with at such a young age and wouldn't want anyone else to go through what he had to. I began this study 3 years ago for my brother. I would love to see the opportunity for change to the life of young boys that live with Alport syndrome. If this drug can extend the life of one's kidneys in order to postpone dialysis and a transplant, what a success that would be. My brother died from cancer from the long-term effects caused by the anti-rejection drugs. Had he been able to put off having a transplant at such a young age, we could have had him around longer than the 51 years that we did. When I started this study, my GFR was 35, and I'm very proud to say it is at 49. Because of this improvement, I am hopeful that I will be able to delay the need for transplant and the terrible effects of anti-rejection drugs, hopefully delaying long-term side effects like cancer until much later in life. Please consider these views when deciding what might be a meaningful benefit that would support approval of this drug. Thank you very much for your time.
Speaker number 4, your audio is connected now. Will speaker number 4 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. My name is Phil Seymour. I am a configuration manager for an aerospace company, and I live in Orange County, California. I have no financial connections to disclose. I'm 58 years old, and I've lived with Alport syndrome all my life, although I was not diagnosed until my mid-30s. At the time, my kidney function was over 50%, and despite continuous monitoring and taking a variety of medications, my kidney function declined to near stage 4 CKD around 5 years ago. All despite my treatment for Alports, which has been take my ACE or ARB, monitor my labs, see my nephrologist every 6 months, eat healthy, and pretty much cross my fingers. This is more of a decades-old kidney failure risk mitigation process than a treatment, a never-ending daily regimen of a plethora of prescriptions and over-the-counter medications. That was all I had, at least until I became aware of the Cardinal trial in 2017, and with the approval from my nephrologist, I successfully enrolled in a phase 2 trial at the local Los Angeles site. In Cardinal, I was able to take the highest allowable dose of the BARD trial drug, and the results have been amazing, even bewildering. For the first time ever, my kidney function actually improved. When I started the trial drug, my eGFR was just around 30, yet during the next few years, I was able to improve my eGFR up to the mid-40s. To me, this meant that my parts of my kidneys were not truly scarred and unusable, as so many Alport patients experience, but were actually increasing their functionality. My outlook in life shifted. I began to envision more travels with my wife and the chance to visit family members without enduring extreme medical precautions. At work, I've been able to delay for years any discussion of extended time off I'd need to take when I progressed to needing transplant surgery. Just like being out of school can cause a student to fall behind, I worry that being out of work would cause me to be bypassed for projects, become inconsequential, or even be let go. With my family, with my wife permanently partially disabled, I've become the sole income earner for my family. Thus, avoiding dialysis and transplant is critical to our financial stability. The only persistent side effect of this trial drug that I've encountered has been the increased muscle cramping that can be minimized with proper hydration. The side effect cost is quite acceptable to me. And beyond cramps, the single events of high liver enzymes and boosted NT-proBNP values were determined to be inconsequential and not indicative of organ decline. I have indeed already seen a bountiful delay of 4 to 5 years of my disease progression, for which I owe to the BARD and to the clinicians involved in the trial. My permanent medical condition diminishes my happiness, especially if it affects me to the point where I need to lessen or give up some of my life's hopes and desires. This new drug has indeed shifted my outlook towards the positive. I've gained years of improved health, and I am pleased with my future trajectory. Thank you.
Speaker number 5. Your audio is connected now. Will speaker number 5 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. My name is Cassandra Smith, and I am only representing myself. I am a patient with Alport syndrome, a mother of 2 patients with Alport syndrome, and a registered nurse. I'm here today to speak with you regarding bardoxolone methyl and the treatment of our rare disease and its potential impact on patient-defined quality of life. While pharmacodynamics, the study design, and statistics have largely been discussed today, I just humbly ask that we recenter our thoughts on those who are directly impacted by today's decision, such as myself and my children. I ask you to reflect on my daughter, Leah, pictured here. She's 10 years old, and she loves ballet, painting, and her brothers most of the time. She has Alport syndrome. And I ask you to reflect on my son, Miles, also pictured here. He is 5 years old, and he adores his big sister, his Nintendo, and his mom. And he also has Alport syndrome. And I ask you to reflect on me and the other patients presenting to you today while making your decision. Who are the names, the faces, and even the voices of the numbers that have been displayed on our screens. And I ask you also to reflect on yourselves and your own lives. Please take a moment and imagine with me. What were you doing at 18 years old? Were you finishing high school, pursuing college or a career? What were you doing at 24? Were you perhaps falling in love or starting a family? What were you doing at 30? Each of these lived experiences are not easily captured or reflected by data, yet they are some of the most impactful, revered moments of our lives. But for patients with Alport syndrome, including many of my own family members, these moments can be limited or even halted by moderate to severe renal disease, renal failure, dialysis and or transplantation, like we've heard today, and the many downstream psychosocial effects such as anxiety, depression, and socioeconomic concerns that arise from the cost of medical treatment and even missed work days, all things that I have experienced myself. But what if we could delay renal failure even by a short time frame? What impact would this have on quality of life? That to me is the primary question that I have been exploring with this medication. So for my daughter, I believe this would allow her to pursue her dream of becoming a professional ballerina, and I believe it would allow my son to pursue love and a family of his own without renal failure halting his plans. And as for me, I believe it would give me more time at the bedside as a nurse and in the lives of my children as their mother. And although this is not a perfect world and no drug comes without risk, I believe that approval of bardoxolone methyl in the treatment of our rare disease would provide those of us living with Alport syndrome with more time prior to renal failure, more time for the opportunities we all wish for our loved ones and have even had for ourselves, leading to an overall improved quality of life. Thank you.
Thank you. Speaker number 6, your audio is connected now. Will speaker number 6 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Thank you. Good afternoon. My name is Ryan Lambler. I'm representing myself, and I have no financial ties to the process. I reside in San Diego, California, and I'm a 43-year-old X-linked Alport syndrome patient. My story is a little different than other patients as I have been blessed with 2 living donor transplants over the last 25 years. My story begins with unexplained hearing loss at the age of 6 and a confirmed Alport diagnosis at age 12. I was told I would need a kidney transplant as a young adult, but a specific timeline was unknown. There were no treatments and no studies to participate in, just simply living life until my renal failure set in. I was extremely scared. Renal failure reared its ugly head at the most inopportune time, my senior year of high school. I was devastated. I was a talented athlete with offers to play in college, but I watched those offers vanish as I had to prepare to save my life. Thankfully, my body held on, and I was able to stave off transplantation, including any need of dialysis, until the following fall after high school graduation. And more importantly, I was one of the lucky ones with a compatible living donor ready to go, my mom. Despite needing to adjust to this new lifestyle of religious medication routines, follow-up appointments, and living every day with a healthy mindset, I went on to graduate college and have a pretty successful business career. Life was moving on and was at its peak both professionally and personally, which was about 10 years post-transplant, when then my transplanted kidney began to fail. My world was shattered once again. It was happening quickly with little time to prepare for a second transplant. I began a life on dialysis, a truly unpleasant experience and one I wish every patient can avoid. However, in the darkness of dialysis, a bright spot emerged. I received news that another living donor was compatible, this time my older sister. So at the age of 31, I received the second gift of life. I'm an extremely optimistic person, so I look at my second transplant as the biggest blessing yet. An entirely new life that I couldn't even have imagined emerged from all of this, and I've certainly made the most of it. Despite my transplant success, we need drugs like bardoxolone to help patients keep their native kidneys longer. Adding treatments like bardoxolone will help L-port patients get further into their adult life, become more emotionally and physically prepared for transplantation, and most importantly, get past many crucial life events that young adults face early on. I experienced firsthand the challenges of being a young transplant recipient, so I know that any delay of disease progression and transplant would benefit patients like me. I support the approval of bardoxolone methyl for Alport syndrome patients. Thank you.
Thank you. Speaker number 7, your audio is connected now. Will speaker number 7 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Hello, I am Sharon Lagas, the co-founder of the Alport Syndrome Foundation, and I have no direct financial relationships to disclose. I'm a patient with CKD stage 3 and a caregiver for 2 of my 3 children who also have Alport syndrome. Ours is the 3rd generation of our family affected by this disease. 7 family members are facing significant life challenges and the possibility of an early death. Today, I speak on behalf of the Alport syndrome community and its 9,700 registered members. We want to emphasize we have a significant unmet need and no FDA-approved treatment. This was documented in the Voice of the Patient report from our patient-focused drug development meeting held in 2018 and summarized in the document we provided in the docket for this meeting. Alport syndrome is uniquely devastating because it causes young adults, mostly male, to go into renal failure during critical times in their lives. Imagine starting college, a career, or a family, and having that derailed because of this disease, or even losing your life at the age of 31, like 2 of our members did recently, both male and female. The current off-label standard of care does not stop disease progression and is poorly tolerated by many patients. Many young adults deal with high potassium due to the standard of care, which significantly impacts their lives and involves regular visits to the emergency room. Patients also report that they cannot tolerate the effects of even the most minimal dose of ACE or ARBs, causing them to be excessively tired or even faint during their daily activities. Alport syndrome patients need new therapies to maintain their kidney function and their quality of life. You are hearing from patients participating in the Cardinal and Eagle trials that have directly benefited from bardoxolone methyl. Some have been on drug for 4 years. These patients report higher energy levels, increased kidney function, and prolonged delay of renal failure, allowing them to participate in their lives and accomplish goals they did not think they would achieve. Without novel therapy, many Alport syndrome patients are guaranteed earlier renal failure, which leads to a poorer quality of life and potential for earlier death. Families like mine have watched generation after generation of their loved ones deal with this disease and its devastating challenges and losses. For this reason, our patients have a high tolerance for less certainty about the treatment benefit, even when faced with risks involved with a new drug. This is because any delayed progression, even if measured in short years, is valuable time in a patient's life. Time to complete high school or college, get married, start a career or family before facing renal failure that forever changes one's life and the lives of their family. Thank you.
Thank you. Speaker number 8, your audio is connected now. Will speaker number 8 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Hello, my name is Janine Reed, and I have no financial ties here. Thank you for the opportunity to share what I've experienced while taking bardoxolone and what this drug has meant for me. I live north of Battle Creek, Michigan on a small sustainable farm. I'm 68 years old, and I'm a retired dialysis nurse. I was first diagnosed with Alport syndrome in 1974. At that time, my diagnosis was based on symptoms and a family history of several affected family members over 3 generations, including my mother, 2 uncles, my grandmother, and a great uncle. Later, my diagnosis was confirmed through biopsy and genetic testing. I began the Cardinal study in October of 2018 at University of Michigan with a GFR of 38. Despite 45 years with a slow decline in my kidney function, after just 3 months of beginning the Cardinal study, my GFR improved to 74. In the 2 washout months during the study, my GFR drifted back down into the 50s. Once I resumed taking the drug, my GFR improved again. When my renal function improved, so did my overall energy and well-being, to the point of being able to resume walking and running 30 miles per week, bicycling, and managing a large vegetable garden, which is a noticeable difference from gardening or walking only an hour at a time once in a while. I also had the energy and motivation to volunteer with Alport Syndrome Foundation, National Kidney Foundation, and Pure Cedar Creek Institute. My retirement years have become dynamic. While on bardoxolone, I've experienced 3 side effects: weight loss, muscle cramping, and an oral lichenoid reaction. All of these side effects have been tolerable when compared to stage 3 fatigue or losing my kidney function. The obvious choice for me is to continue on bardoxolone. If BARD was no longer available to me, I would anticipate that my kidney function would once again decline to the point of needing dialysis or transplantation sometime in the next few years, causing a significant change in my overall health and adding a financial burden for myself and my family. Having a treatment for Alport syndrome is not just important for my own health, but also for the health of my affected family members. I'm especially concerned for my daughter, who has inherited X-linked Alport syndrome from me and currently has very limited treatment options without bardoxolone. I would ask, as you make your decision, that you carefully consider the input from those of us who have had the opportunity to take bardoxolone. Thank you.
Thank you. Speaker number 9 has withdrawn. Speaker number, your audio is connected now. Will speaker number 10 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Hello, and thank you for the opportunity to speak today. My name is Madison Martin. I have no financial disclosures to make. I am a 22-year-old Alport patient who lives in Connecticut. I was diagnosed with Alport syndrome at age 4, which was a shock to my parents because I am the only one in my family with kidney problems. Shortly after my diagnosis, I was started on an ACE inhibitor, enalapril, which I took twice a day. I remained on this medication for most of my childhood and adolescent life, as this was and remains the standard care for Alport syndrome. While my kidney function remained stable for most of my childhood, it slowly started to progress in my early adolescent years. As a result, my nephrologist would increase my enalapril, eventually working up to 30 milligrams daily. At 18 years old, while in college, I went into acute renal failure as a result of dehydration and the high dose of enalapril that I was on. My kidney function bounced back after this episode, but was never the same, and my body could no longer tolerate the ACE inhibitor. Over the next 2 years, my kidney function began its steady decline until 2019, when I underwent an altruistic living donor kidney transplant at the age of 20 years old. I am fortunate that I had the opportunity to receive a donor kidney from my high school attendance secretary. However, because of my young age, it is likely that I will need another kidney transplant in my lifetime. Unfortunately, the Cardinal clinical trial was not available to me when I was younger. By the time I knew about the trial, I was already well on my way to needing a transplant. While the ACE inhibitor may have slowed my progression for 14 years, the Alport patient community needs a more reliable treatment option, as this current standard of care for those with Alport syndrome is not a viable long-term solution. Without a true, sustainable treatment option, I am fearful for my own children, who will likely inherit this disease from me. The only treatment available to me failed, and transplants are hard to come by, which is evidenced by the 13 people that die each day waiting for a kidney. I know I'm not alone when I say I hope studies like this one on bardoxolone methyl can provide Alport patients with a more sustainable and tolerable treatment option. Thank you again for allowing me the opportunity to speak to you all today.
Thank you. Speaker number 11, your audio is connected now. Will speaker number 11 begin and introduce yourself? Please state your name and any organization you are representing for the record.
My name is Clifford Cashton. I'm an emeritus professor of pediatrics and pediatric nephrology at the University of Minnesota with an extensive record of research, education, and advocacy concerning Alport syndrome. I have no current financial relationship with Reata. My goal today is to describe the current treatment of Alport syndrome and the need for safe and effective therapies to improve the outcomes achievable by the current standard of care. When I began my career in pediatric nephrology in the 1980s, Alport syndrome was considered a condition treatable only by dialysis and kidney transplantation. That changed in the early 2000s with the demonstration that early treatment of transgenic Alport mice with an ACE inhibitor dramatically suppressed their kidney disease. Retrospective studies of men and boys with Alport syndrome have shown that early treatment with ACE inhibitors delays the onset of kidney failure by 10 to 20 years compared to patients who do not receive such treatment. A recent prospective study showed that treatment of children with Alport syndrome to further delay the onset of kidney failure in patients with Alport syndrome. One of the attractive features of ACE inhibitor therapy is its relative safety. Adverse effects are generally mild and reversible, often responding to dose adjustment rather than discontinuation of treatment. Ideally, new agents for the treatment of Alport syndrome will also have mild reversible adverse effects. Alport syndrome is rarely a fatal disorder, at least in countries with universal access to high-quality care for kidney disease. Compared to patients with other forms of kidney disease, patients with Alport syndrome have less dialysis-associated mortality, and patient and graft survival after kidney transplantation for Alport syndrome are generally excellent. These favorable outcomes should be at the forefront of analyses of the balance of risk and benefit for new treatments for patients with Alport syndrome. In conclusion, despite the demonstrated benefits of ACE inhibitors in delaying kidney failure in patients with Alport syndrome, there is a need for new add-on treatments to further delay kidney failure while minimizing additional risk. Randomized clinical trials that test the efficacy and safety of new agents in Alport patients receiving the standard of care represent the optimal approach to developing more effective treatment for Alport syndrome. Thank you.
Speaker number 12, your audio is connected now. Will speaker number 12 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Thank you for allowing me to speak today. My name is John Dunlap. I have no financial connection to any company. I do not represent any company, only myself and my family. Again, my name is John Dunlap. I'm vice president of a recycling company, and I am from Nashville, Tennessee. I'm 35 years old, and I was born with Alport syndrome. My mother had Alport syndrome, and my 8-year-old daughter, Nora, has Alport syndrome. As you all know, Alport syndrome is a rare kidney disease. Rather than being a kidney disease caused by eating and lifestyle habits, it's a congenital disease imprinted in our genes. We didn't ask for this, but it was the cards we were dealt. I first discovered I had Alport syndrome when I was 22 years old after deciding to get a biopsy on my own. Growing up, I saw a pediatric nephrologist, but I was lumped in with a broad category of kidney disease patients, never having the opportunity to explore specific treatments for Alport syndrome. Even today, as medical science and technology advances, many nephrologists still lean to the proclivity of generalized medication. However, if bardoxolone were approved, there would be now an option specific to the rare disease that affects my family and I. At 24 years old, I had an emergency open heart surgery to repair a rare side effect of an aortic aneurysm caused by Alport syndrome. Then I had a kidney transplant when I was 28 years old. While raising 3 children and working full-time, 2 years later, I had 2 full-blown strokes that I thankfully recovered from. It was difficult and exhausting. Additionally, I suffer from 60% hearing loss. I want to do everything I can to help prolong this inevitability for my daughter. This is why I'm here today to advocate. If I had treatments like this when I was 8 years old, my developmental stage would have been easier to navigate. I struggled while in high school, college, or early married life, and when trying to start a family in my early 20s. I grew up playing soccer, but I had to deal with constant fatigue, constant issues. Nora, my daughter, is an avid softball fan. She hit 3 home runs this last season alone. She enjoys hiking, mountain climbing, and we even go whitewater rafting. She's a natural athlete, but with specific medication like bardoxolone, hopefully she won't have to deal with the fatigue issues and medical issues that I struggle with. I want her to excel at things that she loves despite having this illness. My hope is that Nora can use this drug one day to allow her to develop into adulthood without the anxiety of kidney transplant leering behind her every step of the way. Nora is the light of my heart, and many times she was the reason I kept going even when I was at my lowest point during kidney failure. We only have one life to live, so I ask that you please allow us to treat Nora properly so she can live her best life. Thank you for your time.
Thank you. Speaker number 13, your audio is now connected. Will speaker number 13 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. My name is Christopher Pack. I represent myself and have no financial disclosures to make. I'm a 32-year-old transplant patient and have been living with autosomal recessive Alport syndrome for all my life. I'm also a father of a 23-month-old daughter that has a chance to be impacted by Alport as well. My doctors first noticed I had kidney issues at 3 years old, and I was formally diagnosed with Alport syndrome at 9 years old through a kidney biopsy. Growing up was filled with doctor visits, constant blood draws, 24-hour urine tests, ACE/ARB inhibitors, and special diets. All of this was done to slow the progression of end-stage kidney disease caused by Alport syndrome. However, it did not slow the progression enough. A year after I graduated college, my kidneys failed. I just started my first job and I wanted to travel the world with my friends. I felt like I was in the prime of my life. All of that was put on hold due to catheter surgery and dialysis. I felt like my life came to a full stop. I was receiving dialysis in the mornings and in the evenings. My schedule revolved around these dialysis sessions. I was on dialysis for 4 years when I got the life-changing call that I would receive a kidney transplant. However, even this life-changing transplant will not last forever. The average lifespan of a deceased donor transplanted kidney is 10 years. I wish there would have been some way to delay my progression of end-stage kidney disease. Delayed progression means I could have avoided transplant in the first place, or at least have delayed transplant to have the time with the gifted kidneys I currently have later into life. After I got my biopsy, I saw my parents get pulled aside by my nephrologist while I was in the waiting room. Looking back, I know this must have been when they received the news that I had Alport. I can only imagine how devastated they were when they heard the news. At the suggestion of my doctors, my parents and I tried different treatments and diets. If we had an option of an Alport-specific treatment when I was young, I'm sure this would have eased my parents' concerns. Now I am a father, and I am in the shoes of a concerned parent. I would give anything so that my daughter does not have to go through what I went through. However, in my lifetime, there are now companies working on Alport syndrome treatments. It might be too late for me, but treatments like bardoxolone and other drugs can give Alport patients a chance to avoid dialysis and transplant altogether. Even delay of dialysis and transplant would give patients, save my daughter, a better quality and longer life. Each and every day matters. Thank you.
Thank you. Speaker number 14, your audio is connected now. Will speaker number 14 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. I'm Stuart Sprague, a nephrologist at North Shore University Health System and professor of medicine at the University of Chicago. I am an investigator in the Cardinal and other RIADA studies. I have no other disclosures to make. I would like to make two main points this afternoon. First, Alport syndrome is a rare genetic disease caused by a defect in type 4 collagen production as a result of mutations in the COL4A, 3, 4, and 5 genes. With advances in testing, we are identifying more patients who have the same genetic defect, such as individuals with thin basement membrane disease and who may be carriers of Alport or have progressive kidney disease without the other manifestations of Alports or being diagnosed as Alports. Indeed, the recent bardoxolone studies have helped us understand that there may be a larger population at risk than those who have classically been diagnosed with Alports. Thus, an effective therapy can slow the progression of disease and could have a considerably larger clinical impact than we thought even a few years ago. Second, having been an investigator in the Cardinal study, I want to share my firsthand observations of the patient experience. In general, patients felt well and essentially had no complaints during both the blinded study and then the open label extension. Side effects, if they occurred, were mild and no one dropped out from my study. In fact, I had patients who were so committed to a treatment for Alports that even though they were going to college hundreds of miles away or even overseas, and not knowing whether they were on a placebo or the study drug, arranged their schedules in order to see me and not miss any of their study visits. Additionally, it was clear that there was a decrease in proteinuria in many subjects who also noted feeling better. Even the few subjects who had mild increases in their liver enzymes were not bothered by it and felt very relieved when it corrected and they were able to tolerate a lower dose without problems. Thus, from my perspective, this drug was extremely well tolerated with minimal to no side effects and had a positive impact both in decreasing patients' proteinuria and slowing progression of disease. Nearly all the subjects I enrolled wanted to know when bardoxolone will be available. In addition, many of them have relatives with Alports and they're hoping that they too may have access to the compound. Finally, during the open label extension study, all the subjects have been very grateful to be part of this study and none have experienced any side effects that concerned either myself or the subjects. With the overall safety data and the effectiveness of bardoxolone in slowing progressive kidney disease in patients with Alports, I very much hope it gets approved. Thank you very much for your attention and allowing me to speak this afternoon.
Thank you. Speaker number 15, your audio is connected now. Will speaker number 15 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. I'm Carrie Willis, Chief Scientific Officer at the National Kidney Foundation. I have no financial relationship with the applicant. On behalf of the Foundation, I want to first thank all of the patients and family members who have participated in our efforts to understand the risks and benefits of potential new therapies from the patient perspective and to help sponsors and regulatory agencies make clinical trials more patient-centered. In 2018, we had the privilege of collaborating with the Alport Syndrome Foundation on a patient-focused drug development meeting, which included 140 Alport syndrome patients and caregivers and 9 representatives of FDA. In live testimony and answers to polling questions posed during the meeting, we learned, and you've heard today, that the most impactful symptoms of Alport syndrome on daily life are anxiety and depression, fatigue, and hearing loss, and that a major source of anxiety for patients is fear of disease progression and the eventual need for dialysis or a kidney transplant. When we asked about potential new treatments, 78% of patients said they would consider taking a drug that would slow progression of their disease, even if its side effect profile was worse than their current treatment. And 74% said that slowing progression was the most important benefit of a new drug, even if it had no effect on hearing loss. The lasting impressions I took away from the meeting were of urgency and hope. People with Alport syndrome face rapidly progressive decline in kidney function and with it a high risk of cardiovascular events and end-stage kidney disease. It was clear patients want access to a therapy that increases their chances of avoiding these outcomes. Many meeting attendees were participating in clinical trials of potential new therapies and expressed concern mixed with optimism that a specific treatment for Alport would be approved soon.
The positive results of the Cardinal trial showing continued improvements in eGFR with bardoxolone treatment over 2 years are consistent with the results of numerous other studies of bardoxolone in other types of kidney disease, which provides additional support that bardoxolone is effective in reducing progression of CKD. We recognize that not all safety concerns can be addressed in a relatively small 2-year trial. Safety data will need to be monitored if approval is granted, and patients will need to be informed of potential risks of long-term use. However, we would ask that the committee bear in mind that given the chance, most Alport syndrome patients will want to try bardoxolone as soon as they can. Thank you for your attention. Thank you. Speaker number 16, your audio is connected now. Will speaker number 16 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Thank you for allowing me to speak today. My name is Jim Simon. I represent myself. As an adult nephrologist at Cleveland Clinic, I have been caring for patients with Alport syndrome for over 10 years and have participated in multiple Alport syndrome trials, including the Cardinal and Eagles trials, and was involved early on as a paid subject matter expert during the design phase of the Cardinal trial. I also served as a paid consultant for Regulus Therapeutics for the design of the Athena trial in preparation for studying Antimir 21, a drug now studied by Sanofi Genzyme. First, as you've heard, I cannot stress how important it is to the Alport community that treatment trials are being conducted on their disease. For too long, their disease was misunderstood, misdiagnosed, or outright dismissed. While RAS inhibition has been shown to slow progression of kidney failure, the potential to have a drug approved specifically for use in Alport syndrome is monumental, to say the least. Second, and slightly contradictory, I will admit that I've been a vocal critic of Reata in my discussions with them from the very early stages of the design of the Cardinal trial for multiple reasons, some of which I will explain below. But I participated in the Cardinal trial because it was important to my patients. Two of bardoxolone's effects on the kidneys, the rise in GFR shortly after starting it and the rise in proteinuria, raised concerns amongst the nephrology community even as patients got excited to see their GFRs rise. Unfortunately, debates about whether these were beneficial or detrimental effects demonstrated how little is known about the true effects of hyperfiltration and proteinuria. BARDs start to increase filtration surface area, suggesting that intracapillary shear stress would not increase. But little is known about any stress on the slit diaphragm this increased flow might create, which is thought to be the true deleterious effect of hyperfiltration. Likewise, the increase in proteinuria is proposed to be due to downregulation of megalin activity, leading to reduced proximal tubular stress at the expense of increased proteinuria. This will be very difficult for clinicians to wrap their brains around without definitive proof that it's not detrimental to the kidneys. Additionally, it takes up to 12 weeks to reach the peak increase in GFR after starting the medication, yet the company was not required in Cardinal to check GFRs 12 weeks after stopping the medicine to assess its lasting effects. And just as importantly, surprisingly to me, studies on Alport mouse models were not required before this drug was approved for study in humans. Fortunately, the evidence Reata has presented from its clinical trials suggested that many of these concerns were not borne out. GFR slopes continue to separate over time, suggesting against a purely hemodynamic effect. The increase in proteinuria has been clinically inconsequential in most cases, and it appears to be safe when given to patients without a history of CHF or volume overload. The data publicly released by Reata appears to show that this drug has a favorable treatment effect and safety profile. As long as the FDA feels that the studies were conducted according to its standards with regards to patient selection, censoring, and data analysis, such that evidence presented by Reata reflects the true effects of bardoxolone on patients with Alport syndrome, I support its approval. Thank you.
Thank you. Speaker number 17, your audio is connected now. Will speaker number 17 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Hi, my name is December West. I am representing no organization and I have no financial relationship with any organization. My daughter's name is Neilani.
The vote results are displayed. I will read the vote totals into the record. The chairperson will go down the list and each voting member states their name and their vote into the record. You can also state the reason why you voted as you did if you want to. However, you should also address any subparts of the voting question, if any. For the record, we have 0 yes, 13 no, and 0 abstentions. Dr. Lewis, are you able to see my message?
All right. Yeah, I think you muted me and I didn't realize it. Thank you. We will now go down the list and have everyone who voted state their name and vote into the record. You may also provide justification of your vote if you wish to. We'll start with Dr. Polvetsky.
Polvetsky, I did no. I think that we've already covered the reasons. I would want to see at least one other marker of kidney function besides creatinine to know whether the changes in EGFR were due to the effects on generation, given the associated weight loss that was seen. And we need to have data with a larger time off of treatment to be able to see the sustained effect of the medication after the acute pharmacodynamic effect has worn off.
Thank you. Dr. Knuckman?
Patrick Knuckman, I voted no. And I want to say, first of all, thank you to the patients and caregiver for your testimonials. They really matter tremendously in what I want to say. In addition to the comments of Dr. Polevsky, I worry about the generalizability of the data presented, especially for patients who genetically are at greater risk of progression. Not only does the data not show benefit, but what little data there is suggests that there is no benefit. Having said that, I am sensitive to the idea that there might be a group of patients with some form of Alport syndrome that could benefit from this. And I think that parsing this out with the caveats about study design and outcome measures, I think would be worth looking into in the future. Thank you.
Thank you. Dr. Mertz, please say your name and how you voted.
Noelle Berry Mertz, and I did vote no. And I want to commend not only the patient volunteers who participated in the trials, but I commend the sponsor for taking on an orphan disease with a novel technology. And it is very hard. We all recognize how hard it is to do not only small trials, but then small trials in a pandemic, and then small trials in patients scattered around the globe. Nevertheless, I voted no, not because of lack of efficacy. They met the primary outcomes as it was designed. It's not a perfect trial. But I am very concerned about the elevation in the UACR, hearing that it is a potent predictor and understanding that the target audience is relatively young. I think that's an unacceptable safety signal. I would encourage the company to explore where there may be more benefit than risk. Thank you.
Thank you. Dr. Menley?
This is Susan Mendley, and I voted no. I want to say that I'm very sensitive to the patients' and parents' perception that any improvement in estimated GFR represents hope. And I recognize the emotional challenge of kidney disease in young patients who have so much life ahead of them. So I think we have more work to do. I agree with the comments that were made by others and would only ask that in a subsequent study there be a larger number of adolescent patients, because I am concerned about the effects on weight gain and statural growth, and would want to, of course, be a benefit in GFR as well. Thank you.
Ms. Alikani?
Yes, this is Jacqueline Alikani. I voted no, and I agree with the feedback from all of the medical experts on the call, from all of the doctors and scientists, and my primary concerns are excluded data, excluded patients, missing data, trial design, very limited to no benefit, and the adverse events.
Thank you. Dr.
Thomas Cook, and I voted no, and I think it's already all been said. Thank you.
Julian Lewis, I voted no. I think that the totality of data, including the preclinical, the data from diabetics, and the data within the Cardinal study is not sufficient to be assured that we would be providing patients with an effective therapy that would not actually cause harm. Dr. O'Connor?
Dr. Chris O'Connor, I voted no. Based on the totality of information, I think there was unclear efficacy on progression of disease with this drug, and I was concerned about the safety profile using the totality of data from Beacon and Cardinal, particularly cardiovascular safety and the BNP and AUC elevations. I want to commend the sponsors for taking this on, and I think there is a path forward, so I'd encourage them to keep going, and I especially thank the patients who participated in the clinical research. Thank you.
Thank you, Dr. Gorman.
Dr. Greg Gorman, my vote was no. My statement, it's unfortunate that this potentially helpful medication had a pharmacodynamic effect on the primary outcome and the GFR measure used. However, that GFR estimate is imperfect. The length of the washout period was of uncertain sufficiency. And despite heroic statistical methods to discern the true effect on GFR from among the noise of that pharmacodynamic effect and measurement error, I wasn't convinced that bardoxolone methyl slowed progression of chronic kidney disease. I might have given it the benefit of the doubt, given the orphan drug status and the lack of any Alport-specific therapies, as poignantly detailed by our public commenters. But that's nullified by the unintended effect of the proteinuria and increased blood pressure, two conditions that have overwhelming evidence that link them to progression of kidney disease. And even if the applicant could demonstrate a statistically significant but clinically tiny renoprotective effect, it might be nullified by the concurrent proteinuric and hypertensive effects over the long term that even a 2-year study would not discern. I agree that the weight loss in a few adolescents is a signal that would argue against approval in the adolescent range that the applicant specifies, and future studies require more numbers of young and adolescent patients. And future studies should also capture quality of life and patient-reported outcome measures better. That's my statement.
Thank you, Dr. Gorman. Dr. Butler?
This is Javed Butler, and I voted no for the reasons that have already been discussed. I would like to thank both the patients that participated in the trial and the sponsors for taking this trial on. A very important question. There are signals that are really encouraging, but the net is not currently explainable in terms of the risk. However, if you look at the epidemiology of the disease, an incredibly distinct minority in single digits participated in this trial, and with no other options, I truly hope that the sponsors plan to do a second trial, and if you get the same signal, especially enriching adolescent patients and those with a lower GFR, then the risk-benefit may tilt in an opposite direction if we have all of these issues related to the benefit being questioned if they are answered both mechanistically and with better data collection. Thank you.
Thank you. David?
Yeah, thanks, Dr. Lewis. I voted, David Molitor, I voted no, and I really appreciate the excellent comments from from all of you. I think you did a great job. I too, felt this was an emotionally charged meeting, and I like Dr. Gorman, wanted to give them a pass, but just couldn't with the totality of information, the number of missing patients, and some of the negative signals that bothered me that we might be trading one benefit for two problems. And so I do applaud the patients and the sponsor, and I hope that there is a pathway forward in the future for these patients.
Thank you. Dr. Casper?
Ed Casper, I voted no. I think that the FDA's charge is to choose for us safe and efficacious drugs, and it's not clear to me that this drug falls into either of those categories. However, I recognize the large amount of work that has been done, the patient volunteers, the public who made comments tonight, the sponsor for taking on an orphan drug, and this is a desperate disease, and it just points to how much more needs to be done going forward. Thank you.
Thank you. Mr. Conway?
Thank you. Paul Conway, I voted no based on efficacy and safety. Safety first. It was disappointing to do so. I understand the courage that's been demonstrated both by the patients, the public speakers, and the company, the applicant, for going into the field of rare disease. It's not easy. I think that patients have demonstrated a much higher risk tolerance than many people can understand. But what comes with risk tolerance and our leaning forward as a patient community is the need for data to make good decisions on. And I was not convinced based on that. And to the patients in particular, I would say, I know what it's like to see a parent look at a diagnosis. And I've been there, and it's tough. But I hope that the patients and the applicant keep going, because I think there is some optimism here and a path forward. Thank you.
Thank you. So I think that I will now try to summarize it. I think the overwhelming thing to say in the summary is that all of us on this committee are emotionally empathetic to the tragedy of this disease. As a rare disease, particularly since it attacks our young people with so much life in front of them. And it's not because of anything they've done. It's a genetic disease. We commend the volunteers. Without them, we would never advance medicine. We commend the sponsor who took on a rare disease, a very challenging study to do or design given the rarity of the disease and also some of the characteristics of the drug that made the study hard to design. I think many of the speakers who voted no, of the panelists who voted no, are hoping that the sponsor will not give up hope, but will focus perhaps on a younger population with a more rapid decline in GFR, where maybe other kinds of more convincing outcomes could be utilized. Overall, the questionable efficacy was troubling due to things like excluded data, differential discontinuation, the question of whether there was a long enough off-drug period to actually demonstrate a benefit of the drug. And also that might have been outweighed if there weren't also troubling safety signals with increased albuminuria, still increased blood pressure, and the potential for increased cardiovascular events with the BNP signal, which translated into events in the Beacon trial. It's unfortunate that the drug, which has a lot of theoretical benefits for sure, this hemodynamic effect that makes it more difficult to study and demonstrate. I'll stop there, and before we adjourn, are there any last comments from the FDA?
Hi, this is Aliza Thompson. I just want to express our, extreme gratitude to the AC members for helping us with this very challenging issue. I also want to thank the sponsor for their work, important work in this area. And first and foremost, I want to thank the patients for coming forward to speak and for working with us in the past and hopefully working with us in the future to find a path forward for safe and effective treatments for this truly horrible disease.
I will add thanks to all the patients who took time to speak to us today and the volunteers for the study. I also want to thank the FDA and their staff. I think they clearly put in a lot of thought and a lot of work and probably a lot of heart and angst into their comments and preparation. They were extremely helpful to the panel. I want to thank the sponsor for taking this on. Again, I think you had a very, very challenging task at hand, and I hope that you will take into consideration the comments of the panel about going forward with perhaps a different patient population and a different study design. We will now adjourn the meeting. Thank you all. We made it.
The meeting is now.
Hi, everyone. Welcome to the Improving Clinical and Post-Market Evaluation session of the FDA Science Forum. I'm Julie Schneider from the Oncology Center of Excellence, and I'll be moderating this session.
Ну что, идем в пол. Посмотрим секунду, как он откроется. NASDAQ. В целом неплохо, я думаю. Сняли 34%. Так. Вот. Че, мы отобьемся, скорее всего. 68. Может, сразу на дно. Хер его знает. Может, сразу. Так, ну чё, когда открытие? Нету инфы. Хорошо, она должна упасть. Еще не написано. Понимаю, что не объявляет об открытии торгов, если все закончилось. Хрень какая. Может даже 87. сейчас приостановят торги на СПБ бирже. 15% падения за, 4 часа. Нет, это не подойдет. Вот это. После 56 закроют сразу всех и будет падать без откатов. Даже не пытайтесь ловить. Ни в коем случае. 56 пробьет и закрывается СПБ биржа. И там падать. Очень сильно. Где-то до 17. На 71% скорее всего пойдет сейчас. Пам-пам-пам. Зон включить. Так. Всем спасибо, ребят. Всем до свидания.